Hello. Hi, everyone. Thank you so much for joining us. I'm Karen Howard, the Director of Policy and Advocacy at Mental Health America, and I'm so grateful to have you joining today's program, the National Policy Institute, a bi-directional approach to bring together public health and mental health. Today's program will pack a lot of information about mental health care, which most often focuses on an individual, and public health, which encompasses large populations. If we want to get upstream and address mental health early, we need to merge these two different approaches in a bi-directional way. For those who may not be familiar with MHA, we were founded over 100 years ago by Clifford Beers of Connecticut, who had lived experience with a mental illness and experienced the shame, delay in care, and abuse in treatment with no expectation of full recovery that is all too common still today. His work led to the consumer advocacy movement, which has helped inform legislation over decades, such as the Community Mental Health Act signed by President Kennedy in 1963, the Mental Health Systems Act of 1980, the Mental Health Parity and Addiction Equity Act of 2008, the Affordable Care Act in 2010, and more recent bills such as 21st Century Cures and the Support Act. Our vision is prevention for all, early intervention and identification for those at risk, integrated services and supports for those who need them, with recovery as a goal. To achieve this before stage 4 philosophy, today's program will discuss recommendations for decision makers to improve mental health care and supports in public health planning and implementation, especially as it relates to workforce, systems, research and data collection, in current policymaking, including bills and resources considered by Congress and regulatory initiatives by administrative agencies. In this program, we are especially honored to highlight the voices of recent high school graduates and young adults with lived experience, because their voices are not often included in decision-making, despite a youth mental health crisis that began before the pandemic and which has become worse during COVID-19. Most recently, CDC data released in April show that 44% of high school students reported feeling persistently sad or hopeless in the last year. And MHA screening data shows increased suicidality and mental health problems, highest in youth ages 11 to 17 years old. You'll hear more about trends in our online screening data from MHA's Teresa Nguyen, moderator of the first session, immediately following welcome remarks from MHA's new president and CEO, Schroeder Stribling, as well as opening remarks from Kaiser Permanente's national leader on mental health, Don Mordecai. Let's turn to Schroeder and Don now.
Hello, and welcome to Mental Health America's 2022 National Policy Institute, a bi-directional approach to bring together public health and mental health. I am Schroeder Stribling, President and CEO at the National Office of Mental Health America, and I want to begin by thanking Kaiser Permanente for your extraordinary partnership in sponsoring the MHA Policy Institute and working with us over the last 3 years. The purpose of Policy Institute is to inform federal and state policymakers about the best ways to promote mental health and support recovery from mental illness. Therefore, if there are legislators or others whom you think would benefit from this discussion, we welcome you to share the recording link after our conclusion today, as the meeting is being recorded and will be available on YouTube. We chose our topic this year out of concern about the historical disconnection between the public health and mental health systems, and our sense that the COVID-19 pandemic has presented us with a unique opportunity. For example, we worked hard this year to have schizophrenia, bipolar disorder, depression, and other mood disorders identified by the CDC as high-risk conditions for mortality with COVID. Additionally, as we faced accelerating workforce shortage issues, and with more than half of the counties in the US having no psychiatrist, we worked hard to promote the inclusion of peer specialists in Medicare. In this vein, we want to continue to identify ways in which public health and healthcare agencies can move resources to meet individual and community needs sooner and more effectively, This we know will save lives, reduce individual distress, and strengthen communities. In this difficult time, we see an opportunity to reimagine how community-based agencies supporting prevention and public health can better integrate with and engage healthcare systems to meet the increased needs of the population at large, both now and in the out years as we collectively recover from the pandemic. Primary prevention and early intervention remain fundamental principles of our work, and they span the life cycle from perinatal to early childhood to youth and young adults to the elderly. Likewise, secondary prevention is also critical to supporting the well-being and recovery of more seriously impacted individuals who experience crises or manage chronic conditions. Writ large at MHA, our mission is to reach individuals as early as possible with effective, accessible, and culturally responsive care. We know that doing so requires us to expand our thinking with a public health perspective. Attending to the social determinants of health, the conditions necessary for whole person health and thriving, is imperative. Integrating community-based care, which attends to basic human needs as well as specific mental health interventions for high-need individuals, was the focus of my work prior to joining Mental Health America almost a year ago, and I'm so proud to see MHA embracing these priorities for the future. It is both an honor and a pleasure to be working with my new colleagues at the national office and across the country and in our network of Mental Health America affiliates, and with all of our other policy and practice leaders, partners, and stakeholders. Thank you. And now we will turn it over to Don Mordecai, Kaiser Permanente's national leader for mental health and wellness, for remarks about their work over the last year.
Greetings. Thank you everyone for joining us today for Mental Health America's 2022 Policy Institute. I'm pleased to kick off this important event focused on strengthening the connection between mental health services and our public health systems. With the stress and social isolation brought on by the COVID-19 pandemic, especially among youth and older adults, we find ourselves in a mental health crisis, one that requires robust public and private coordination and collaboration to overcome. There's a renewed urgency to provide universal access to effective, equitable mental health and addiction care services. In fact, several panels today will focus on building a stronger mental health workforce, as this is an issue that is critically important to the future of mental health care in our country. Kaiser Permanente is currently implementing a collaborative care model within our mental health and addiction care delivery system to provide our members with better access to care. This model provides support for patients managing common conditions like depression and anxiety. It also requires fewer specialty mental health resources and nearly doubles positive outcomes compared to standard primary care treatment. This is something which the whole country could benefit from. One of the most important things we can do is gather thoughtful people together to explore how we can reimagine our existing systems and do better as a society. In today's virtual event, we'll share ideas on how to better integrate our existing mental health systems with public health. We'll also hear ideas and reflections from the leading minds working on this issue, including from our federal agencies, national mental health organizations, and youth voices. The experts we have convened today will dive into the challenges and opportunities associated with building and retaining a racially and culturally diverse and geographically balanced workforce of clinicians. I'm excited to see these leaders come together and discuss a bi-directional approach to connecting mental health and public health. There will also be insightful conversations focused on growing the mental health workforce, supporting approaches to prevention and sustainable financing, and building healthier schools and communities. In closing, I want to share a passage from our U.S. Surgeon General, Vivek Murthy, and his Protecting Youth Mental Health Advisory Report. Dr. Murthy said, "The challenges today's generation of young people face are unprecedented and uniquely hard to navigate, and the effect these challenges have had on their mental health is devastating." Consider the recent national surveys of young people showing alarming increases in the prevalence of mental health challenges. In 2019, 1 in 3 high school students and half of female students reported persistent feelings of sadness or hopelessness, an overall increase of 40% from 2009. Dr. Murthy went on to say, "It would be a tragedy if we beat back one public health crisis only to allow another to grow in its place." I'm incredibly happy that Kaiser Permanente is once again sponsoring this year's Mental Health America Policy Institute to strengthen the connection between mental health services and our public health systems to address our current mental health crisis. I hope you enjoy today's conversations and are compelled to leverage innovative ideas and resources to support the growing needs of our community members. I'll now turn it back to the Mental Health America team to start our 2022 Policy Institute.
Thanks so much, Don. I'm really pleased to introduce MHA's Chief Program Officer and Vice President of Research and Innovation, Teresa Nguyen, who works to improve access to mental health care through data and digital solutions, and recently launched a new Center for Research and Innovation where you can find on MHA's website at mhanational.org/center-research-and-innovation. You can also follow along and join the conversation on social media. And to do so, you can follow us on Twitter using @mentalhealtham, and on LinkedIn, Facebook, and Instagram using our full handle @mentalhealthamerica with hashtags MHA Policy 2022, hashtag Public Mental Health, and hashtag Before Stage 4. Take it away, Teresa.
Hi, everyone. Hi. Yes, my name is Teresa Nguyen, Chief Program Officer at Mental Health America, and thank you for joining today's session, a Q&A on the CDC and SAMHSA's approach to prevention in public and mental health. And today's speakers include Captain Chris Jones. Dr. Jones is currently the Acting Director of the National Center for Injury Prevention and Control at the Centers for Disease Control and Prevention. When not serving as the acting director, Dr. Jones is the deputy director of the NCIPC. And our second guest is Dr. Anita Everett. Dr. Everett is the director of the Center for Mental Health Services at SAMHSA, the Substance Abuse and Mental Health Services Administration. In this role, she provides executive leadership for federal efforts to improve the nation's mental health service systems. And I'm going to kick us off by setting the stage on what we know about changes in mental health across the country before moving into our QA with our guests. Okay, great. So I'm not sure how many of you know, but long before COVID-19 happened to us, the youth mental health crisis issue has definitely been on the eyes of public policy epidemiologists as a concern, right? Depression, suicide, and self-harm behaviors were on the rise, although substance use behaviors were decreasing. And then during the pandemic, we saw an increase in substance use among our young people, which was an area of concern. As part of MHA's work, we have been publishing annually a report since 2014 titled The State of Mental Health in America, where we compile high-level numbers across the country about our trends. What I want to move us towards, however, is some data that we have that provides real-time understanding of what's been happening during COVID. So MHA runs a screening program that we started in 2014. Historically, we've had around a million users a year come to take a mental health screen on our website. This jumped in 2020 and 2021, where now we're serving around 5 million users a year and have completed over 50 million users have completed a screen. And this data provides us with enormous opportunity to understand what the concerns and opportunities are to support young people and all individuals struggling with mental health conditions when they first start recognizing that something is a challenge. What I do want to share about our data is that our data also tracks with census data for the most part, with some nuances that are specific to mental health. So our data tracks young, 35% of users are under 18, another 30% historically are around 18 to 25. This is consistent with the lifespan development of mental illness, and also skews female, for example, which is also consistent with mental health help-seeking behaviors. What we know about our data is that the people who are coming to take a test come from online search engines, searching something like, am I depressed? Am I stressed or depressed? I want to die. They are scoring severe, moderate to severe, primarily for the conditions that they're looking for, which indicates that they know something is going on. But many of them have never received treatment and are not currently receiving treatment. So in 2020 to 2021, that rate increased from ability to seek treatment. It decreased, actually. So 57% historically had said that they had not received treatment, and that jumped up to 64%, which indicates both new people who are struggling with mental health for the first time, and probably some indication, the data showing what we all feel when we went to go seek care, which is that provider shortages and burnout were a major concern. We do not often see movement in major data areas, possibly except for during a pandemic. And I want to show you a couple of these trends and what they look like. During, historically with our data between 2015 and 2019, MHA screening data saw a relatively stable rate of users who endorse suicidal thoughts. The answer question number 9 in the PHQ-9. And that jumped up, however, in June of 2020 and started to take a gradual uptick. And for us, this is interesting because where our data historically tracks the behaviors for students, remember, most of our data are young, we do see upward trends in distress happening, for example, right before school starts. Here, in this case, we saw the movement upward start in June, which is when many students went into lockdown after some period of time, and then were at home primarily during the pandemic. And we have not seen this rate come down from between 37 to 41% since it rose back in 2020. And suicide and suicidal thoughts are a mark of distress. And we're certainly all keeping an eye on when this might come down as a sign of the alleviation of that distress for our community. Another similar trend that I want to share, however, is that while we do know that the number of screens that increase rose, this may be tied to some of the work MHA has done in our reach, our marketing. It's hard to disaggregate how this jump increased in terms of the number of users who came to take a screen from May 2020 with our own work and what's COVID, right? There's a correlation here. What is more likely to be COVID related, however, is this line that you see, and that is the number of young people who were scoring at risk for a mental health condition. Something as concerning as even psychosis, we saw a rise in the number of users who are scoring at risk for any condition that they were taking, and this was across the board for all mental health conditions, and even for psychosis. That rate went from an average of around 66% endorsing symptoms sufficient to score at risk, all the way up to now 76%. And that number has also not decreased since 2020, which indicates that while we experience the distress of suicide, we're also experiencing enormous stress. And the stress that results in the likelihood that someone, for example, might convert and experience a psychotic break for the first time is quite concerning. So we will be, looking at what this means to support young people who may develop bipolar disorder or schizophrenia related disorders much earlier in their life than they might not have given no pandemic. I want to also point out that this is in our historical data, individuals who identify as Native American or identify as multiracial have consistently come out with higher concerns. They're more likely to score at risk. They report higher rates of distress, higher rates of self-harm thoughts, for example, that you see here. And so I just want to point out from an equity lens that these are populations that historically are not focused on sufficiently, and it's important to do research and to do work to make sure that we're supporting underserved communities. And just a note specific to COVID was the jump for the Asian and Pacific Islander community, the change between 2020 and 2021 on not just increase in self-harm thoughts, but also rates of change in reporting anxiety and distress and concerns about COVID in the API community were a significant jump that we did not see in past years, was consistent with CDC data, and reflected here when Asian community members came to screen and reported increases in overall mental health distress. And I want to share a resource that MHA has. In February 2022, we did launch a mental health at risk dashboard. We have sufficient data now to be able to map much of our data onto at a county level, and we will continue to update this mapping dashboard. And what I think is so wonderful about this is we do have enough data now to provide more real-time analysis. And we hope that this will improve some of our research that we're collaborating with on suicide prediction models, and how do we look at a more granular level to support underserved communities and make sure that resources that are allocated in communities are allocated appropriately to where risk is seen. This is an example of that is the implementation of the 988 policy that we have going implemented across the country. And finally, I just wanted to share with you a couple resources that I highlighted a summary: our MHA online screening program, the dashboard, and the state of mental health in America. And that is it. And now with that, I'm going to take a pause so that we can bring in our speakers and start our Q&A discussion with Dr. Jones and Dr. Anita Everett. Welcome to Dr. Jones and Dr. Everett. How are you today?
Doing well. Thanks for having us here.
Yep.
Yay. Yep. Well, we really so appreciate it. And I'm going to actually kick off the first question to Dr. Jones. Can you share with us what data are collected at the CDC, and how does this data inform your public health approach?
Sure. So CDC has a number of data systems that collect information on a range of health outcomes and health risk behaviors. And that ranges from surveys focused on youth, like our youth risk factor behavior survey, as well as adults in our behavioral risk factor surveillance system. And then we have other surveys that collect information on a variety of provider services that are provided both in the hospital and emergency department setting, as well as in the primary care setting, and then longitudinal studies that look at the impacts of a variety of health issues. We also collect mortality data through our National Vital Statistics System, which is really the census of what causes deaths in the United States and what's used to track mortality data. And then we have syndromic surveillance data, which is near real-time data that collects information on emergency department visits, which has certainly been an important data source during COVID in helping us to understand changes in emergency department visits during the pandemic. Specific to mental health, the YRBS, which I mentioned, is one of our go-to data sources that looks at suicidal ideation, attempts among high school students in 9th through 12th grade, their connections to substance use, other health behaviors, other forms of violence that individuals might be exposed to. And then in the BRFIS data, the adult data, we're able to look at mental health conditions as well as their interconnections to other health outcomes, as well as early experiences such as adverse childhood experiences in early childhood and how they relate to health risk behaviors and health outcomes in the adult population. And then, of course, in our mortality data, we track things like suicide, drug overdose deaths, other deaths related to mental health conditions that provide important insight into who is being impacted by those pressing public health issues. And then last I'll say is that during the COVID-19 pandemic, we've really been stretched to be innovative in collecting information because many of our data systems did not give us timely enough information to really understand what was going on. So we've fielded online surveys to understand health and mental health impacts of COVID-19, both among youth and adults. We worked with the Census Bureau to do bi-weekly surveys using text messaging to the US population to understand mental health changes, access to mental health care and other health services, and then also used innovative data science techniques like machine learning and natural language processing to look at Reddit data, Twitter data, Facebook, other data to also try to use those data sources to help us understand what's going on. And all of these surveillance systems are really in the service of helping to advance our programmatic and policy work to improve health in communities across the country.
That's wonderful. Thank you for that. And Anita, I want to ask you the same question. What data are collected by SAMHSA that informs, and how does that inform your public health approach?
Sure. So we have several different tools that we use to collect data, and whereas the CDC's mission is much broader to all of health, ours is more narrowly focused on mental health and substance use disorder conditions. One of our main long-term surveys is the National Survey on Drug Use and Health. Years ago, it used to be called the Household Survey. And that is because it was actually collected in person, door to door, on a representative sample of individuals across the nation. And that's still one of our main surveys. That started out as to capture addiction and substance use disorder, but over the last several years has broadened to include quite a bit of information that in some ways is complementary to what the CDC collects on mental health and also on suicide and some of the antecedents to suicide, which we feel like is really important. There are a couple other data sources that we collect in the style similar to what Dr. Jones described as this syndromic surveillance. We collect drug awareness data from emergency rooms, and the point there was to detect emerging trends as they appear in emergency departments. So we have several other tools like that. I did want to talk just a little bit about the NISTA, if I could, and some of the findings that it's helped us with. One of the as Dr. Jones mentioned, the CDC keeps several important surveys and also death data on suicide. And when you think, very much about suicide, it's the kind of problem to me that represents a necessity for a partnership between public health interventions and health delivery interventions. You can't train enough primary care or specialty providers to address suicide and fix the problem. Neither can you have enough public health initiatives to fix the problem. You need some of both. And so one of the ways that we use NISTA to think about that is to help educate the general public about what I call antecedent thinking, planning, attempting, and actually death by suicide is the final sort of place that we don't want to be in. So we do capture that kind of information in the NISTA.
That's wonderful. I think you started to touch on this. This question is for both of you, but what are the differences between the two agencies in how you approach public health? What's SAMHSA's role versus what is the CDC's role, and how do you all work together? I don't know who wants to go first. Do you want to go first, Anita, since you?
Oh, sure. Yeah, I mean, we work together where we can, and we have quite a bit of overlap. I know the CDC has a whole section that's sort of led in the interest of mental health. It's kind of as I understand it, kind of a crosscut that goes across. And we are, I think we have a pretty close working relationship. We're more also into the actual services delivery component. Many of the grants that we fund support direct care type services, not in the style that Medicaid and Medicare do. We're not a payer, an insurer per se, but one of the ways I think about our grants is startups. They enable a clinic to take on a new program, or a school. We have, I think we'll talk just a little bit later maybe about some of our school-based programs, but we have we have, we enable support for services to start up.
Oh, that's wonderful. Dr. Jones, do you want to add to that?
Sure, yeah, and I totally agree with Dr. Everett that we do work very closely together through a variety of different interagency activities. I think suicide is a very good example where we have a comprehensive suicide prevention program in the Injury Center here at CDC, and we work closely with SAMHSA suicide prevention folks and programs in the field that fall under Anita Center at CMHS. And we also co-chair an interagency group within HHS on suicide prevention and crisis care, which really brings in the full breadth of HHS agencies working together to address these pressing public health issues. But at CDC, our fundamental approach to addressing public health issues is through use of the public health model, which really has 4 components. So using data and research to define and monitor the problem, identify risk and protective factors, developing and testing evidence-based strategies, and then assuring widespread adoption. So that's sort of the holistic approach that we bring to the issues. I think how that is operationalized is that we work with public health agencies, education agencies, and a range of community partners to really focus on preventing risks. And in the context of mental health, risk of negative mental health outcomes and promotion of supportive caring environments to reduce risk in the first place, and then to help promote resilience and well-being. And I think increasingly, as we've built out our suicide work, our adverse childhood experiences prevention work, and our overdose work in the Injury Center, a core part of our work has been very intentional in trying to build those linkages in communities to connect people into the services that Anita talked about that SAMHSA and others are providing. It's not CDC's job to be that service delivery provider, but we do think public health has an important role in being that connector in building the capacity in communities and bringing multiple sectors together to address underlying upstream drivers of risk, promoting protective factors, and then helping those most at risk connect in to those services. And we do that again through funding of health departments, funding education agencies, as well as funding of community partner organizations as well. And then the last area where I'll say that we are actively working closely together is around 988 implementation. And this is, again, a whole of government, a whole of society effort to get everybody together. And Anita and others at SAMHSA have been leading that effort, but we were able to loan one of our communicators at CDC to help with the messaging around 988 and stand ready to engage with our state and local public health partners to make that a successful launch, recognizing that there is so much that needs to be done across the country to support that effort.
Yes, no doubt. And I appreciate that the integration of your work stacks nicely with data as the grounding root for both of you all, with movement towards implementation. I love what you described, Dr. Everett, about SAMHSA being a startup. How do we build knowledge and move that into systems by funding communities to provide implementation of services that we know work best. So that's really wonderful. I think everybody has their eye on COVID. It feels like it's been a long couple of years and it's hard to know where we're heading. But I wanted to open up a dialogue with you both about how each agency is addressing COVID and those continued mental health impacts. What are you thinking about? What are you most concerned with? And where do we go from here? So who wants to start?
I mean, I'm happy to kick it off. Certainly from a CDC perspective, we stood up a really cross CDC COVID-19 response starting in early 2020. I was deployed to the COVID response in February of 2020, really even before cases started showing up in the US. And what I think was so important, and certainly SAMHSA was a key part of this, is that very early on, based on prior experience with the Gulf oil spill, Hurricane Katrina, other large-scale disasters, we knew that we needed to be thinking about mental health and substance use. It was not going to be something that a year in, we're like, oh, we need to be paying attention to this. So we were intentional at CDC in convening a group of folks who sit across different components of CDC, but have equities, programs, expertise in the areas of mental health, substance use, resilience, well-being, to actually create a group within the response that could help lead those efforts. And a lot of that focused on putting out data and publications to understand what was happening with mental health or suicide or overdose, who was impacted, how was risk changing as the COVID-19 context changed. We developed guidance for healthcare, schools, and community settings. We released a toolkit specific for parents and focusing on ensuring children and young people's social, emotional, and mental well-being during COVID-19. And then again, as I mentioned earlier, we tried to leverage innovative data sources to help answer some of those key questions about what was going on with emergency department visits, what was going on with prevalence of depression or anxiety, or pandemic-related stressors, and putting that information out into the field. We also provided specific funding to state and local public health agencies, tribal organizations, and our NGO partners to advance efforts around prevention and response of suicide, overdose, ACEs, intimate partner violence, all things connected with mental health during COVID-19. And our school programs also put out funding and resources to support social emotional learning and well-being aimed at teachers, students, people getting back to school to help support those efforts. And then we had some communication campaigns. Our largest campaign was called How Right Now, which really did focus on resilience and healthy coping skills. And then we had a specific focus on return to school at the beginning of this past school year that focused on educators as the primary audience and really putting at the top of their mind, how are we thinking about social emotional support and well-being for students and ensuring that there is sort of a positive social emotional climate in the school setting. And I would say that SAMHSA was our partner throughout all of that. We were passing data to SAMHSA on emergency department visits and suicide in near real time. We essentially sent a report every week or every other week because we were all trying to understand how can we best leverage our resources and expertise to address this challenge.
Really comprehensive. That's wonderful. Dr. Everett?
Yeah, and whereas the CDC's response is much broader, their responsibility and role is much broader to all of COVID. We've been a little more narrowly focused on the behavioral health space or components of that.
Yes.
Or so more focused, I would say. So during the pandemic itself, we received quite a bit of money from multiple different bills to provide support to communities. Some of our priorities with that had to do with providing general social emotional supports, which usually came through state departments of behavioral health and often came out to communities in terms of resources, but also warm lines and call lines and lines like that were set up. We have a crisis response program that was also initiated, and all of the 50 states and our grantees were the recipients of those grants. Those are grants that we operate together with FEMA. And typically are set up for after natural disasters like hurricanes and things like that. But in this case, because the Stafford Act did declare a federal disaster, COVID as a federal disaster, we participated with all of the states. And those are the kinds of activities. We also had a whole line of grants that were designed specifically for community mental health centers to keep them going because so many of them experienced changes in their normal revenue base related to COVID. Also, a number of our grantees, of course, made the switch or transitioned to telemedicine and becoming increasingly dependent on that and how that was going to work for regular office visits, but also all the other kinds of things that are involved in working with folks that have long-term mental illnesses, like case management and other outreach types of things. What of that could be done by telemedicine versus indeed it required actual physical outreach to happen. So we've done a lot of that. Right now, we're involved in two different lines of work that have to do more with long COVID. So there's a national thing that's actually headed up by the Biden administration and the White House that's looking at all of government response to long COVID. And our particular area of focus is the two main focuses have to do with research and where are the gaps right now and what is set up currently to research, and then also services. And so we're actively working on compiling an inventory of cross-government services there. And that will include, the services component will include an element of services like disability, eligibility, things like that, that Social Security is involved with. So that's an element that's, a strong element that's involved in other disability related services, services that are set up in the healthcare space, and then also behavioral health care. And for us, that includes mental health effects of COVID and long COVID, substance use related effects, and also bereavement, because so many of our American families have been touched, all of us in one way or another, but many by unanticipated or premature death related to COVID. And we have all read about the number of new, children in particular that have been affected by that. One other quick thing I'll say is we're also pursuing a line of work related more narrowly to the mental health effects of COVID. And we know upwards of a third of people who experience long COVID additionally experience cognitive abnormalities, brain fog, and or emotional disturbance, and other features that can feel like anxiety disorder and or be anxiety disorder. So we're really starting to dig into trying to characterize what those are, and then also develop some materials that could be used in clinic settings to educate the workforce on how to recognize and manage long COVID, particularly the behavioral health aspects of long COVID.
I appreciate you bringing up both warm lines and the toolkits you mentioned, Dr. Jones. I think those are a great example of your different approaches to public health, one being education and wide dissemination. Nita, you're talking about how do we disseminate rapidly the changes and meet the needs of our community by implementing rapid response. That's wonderful. Long COVID has been on a lot of our minds, and just what does it mean to struggle with a chronic health condition? And many of us who live with multiple mental health issues, history of substance use issues, we know that the inflammatory response in our body is profound, and that impact is long term. And we appreciate that there's a focus there, because I think there's a desire to kind of want to move on. But for many who just continue to feel the impacts, I think it feels heartening to know that the government is thinking about what this means for overall health for our community. So thank you. I'm going to shift to asking you both about some key program areas that I think we're all very interested in. So I want to first ask Dr. Everett to share about Project Aware. Oh no, is this Project Aware at SAMHSA?
Yeah,
Yeah.
We both both agencies are very concerned about the impact of COVID on kids, and even before COVID, of course, concerned about the social and emotional well-being of children and setting them up for success as best we can. So Aware is a program that we have that's a school-based mental health program, and I like to think of it as having three elements, which include that sort of spectrum from what you might call public health all the way into actual referral to treatment for individuals who need treatment. And so the three layers are what we would call universal intervention, or something that affects all the kids, so that the grantees that work with this program are required to attend to and develop and foster a culture that supports a healthy social emotional learning, so a good school climate. The second tier has to do with ways to identify and sort of work with kids at risk. Kids who may be in a situation where they've lost a parent or grandparent related to COVID, for instance, would be a kid at some risk, who may or may not have actual problems, but at risk. And so this has to do with teaching the individuals that interface with schools on developing an understanding of kids at risk. And then the third of these is a pathway to referral, so that kids who have, or the smaller number, but have crossed the threshold into something that may or may not wind up with a diagnosis and need specific specialized treatment. So those three layers, universal, selected, and indicated, I guess you'd say, are our sort of ways of thinking about that in Aware. Congress has been very interested in that program. We've gotten quite a bit of additional money over the last several years, and two lines that they've been particularly interested in have included adding in more explicitly trauma-informed care as an approach based on the ACEs work that has its heart in the CDC, and then also suicide prevention work is a required element. Some of our grantees took that on and some not, but moving forward, all of them will be required to have some attention to suicide because, I think many of us, many of your members are aware, I'm sure, suicide sadly has reached new lows with regards to the age group of kids
Yeah.
that are thinking, planning, and attempting suicide.
Yeah, absolutely. And for Dr. Jones, similarly, we would love to hear about Healthy Schools and how is that program, and tell us more about it.
Sure. Well, our Healthy School program sits within our Chronic Disease Center, and it currently provides funding to 16 state education agencies and 5 non-governmental partners. And it's sort of a unique program in that it works with state school systems, communities, and national partners to focus on promoting health and well-being of children and adolescents in schools. And it uses the whole school, whole community, whole child model as its framework for how the funding is put to use. And that is a student-centered approach that emphasizes the role of community in supporting the school and the importance of evidence-based policies and practices. The funded jurisdictions focus on promoting healthier nutrition options in education, comprehensive physical activity programs and physical education, improved processes and better training to help students manage chronic conditions, health education that instills lifelong healthy habits and health literacy, practices that improve school health services and links to clinical and community resources, and practices that promote mental health and social emotional learning. And the funding from CDC supports programmatic efforts, technical assistance, specialized tools, and training in those jurisdictions. And ultimately, the program aims to create healthier schools where students are safe, engaged, supported, and challenged. And I also wanted to mention our work in the Injury Center around preventing adverse childhood experiences, as Anita mentioned, that's sort of foundational to challenges around substance use and overdose and mental health. And we know that experiencing trauma, early adversity in those early years of life can have profound effects across the lifespan. And we currently fund 6 states in our comprehensive ACEs prevention program, which I think complements the school-based work that Anita's talked about at SAMHSA, as well as our school-based work at CDC, to really focus on primary upstream prevention, changing the community context, instilling resilience, and ultimately safe, stable, nurturing families and environments in communities to reduce exposure to ACEs and to have lasting effects on mental health, well-being, and health overall. So I think there's a lot of work that is, I think, really important coming out of COVID-19 and this looming mental health crisis that we are trying to get ahead of. Certainly have some catch up to do as well. And I think ACEs prevention and the work and their school-based work and the work that Anita's talked about under Project Aware really provide that front-end roadmap to get ahead of these issues in the long term.
Wonderful. Thank you so much for your time. I think that was a great summary and 2 wonderful programmatic examples of your distinct differences in the way you work together. So I want to thank you for your time today. And I hope that in all of your endeavors, you have the best of luck to help us to create a stable and healthy community. Thank you so much.
Thank you. Thank you very much.
Thanks so much.
Thank you so much, Teresa. The discussion was extremely informative and helped clarify which agency collects what data and how that relates to the mental health of the population. It was also helpful to hear that suicide prevention is an area of great collaboration between the 2 agencies, including 988, the new 3-digit number launching on July 16th that will serve as an important public health initiative providing an easy-to-remember number so that more people connect quickly to a mental health non-police response when they are in crisis. It was wonderful to hear about upstream efforts by the agencies to educate educators and other school professionals. And we also heard that it's important to reduce exposure for young people to adversity, violence, and trauma in childhood. Knowing of the increased risk of violence and trauma experienced by communities of color in the US, this is a good time to discuss equity. Just 2% of psychiatrists are Black, less than the number of Black physicians overall at 5%, and a majority of Black and Latino or Hispanic adults have no access to mental health treatment. It's worse for addiction, as nearly 90% of Black and Latino adults with substance use disorders have no access to effective care. And additionally, considering the impact of social determinants of health and environmental challenges, the overall trajectory of Black, Indigenous, populations of color, or BIPOC folks show great disparities in contrast to white populations. In our next panel, we'll discuss how to better address some of these disparities through investments in peer specialists, youth peers, promotoras, and how these workers can be considered part of the public health workforce. Currently, they're already recognized and funded by HRSA's BWET program, the Behavioral Health Workforce Education and Training Program. However, these allied health workers are often undervalued and underutilized. I now have the pleasure of introducing an esteemed colleague and longtime peer advocate, our 2021 Clifford Beers Award winner, Karis Myrick, who will moderate our first panel, Investments for an Equitable Public Health Workforce. Karis has testified before the Senate and House committees, is co-director of the Mental Health Strategic Impact Initiative, and is host of her own podcast. The panel will begin with Karis addressing Dr. Vikram Patel, who will discuss community health workers, and Gloria Lavia, who will discuss her experience as a promotora. It will then conclude with a one-on-one with Vale Smith and Yesenia Anaya, who will both discuss the importance of peer support.
All right, so welcome everyone to our panel today. We're going to be talking about investments for an equitable public mental health workforce. Before I introduce the panelists, let me give you a background about what we're going to be talking about. So we know that mental health needs have risen drastically during the pandemic, and data shows increased anxiety, depression, suicidal ideation, trauma, and PTSD. Hotlines and warm lines across the country have seen increases in call volume. And then the healthcare workforce and frontline workers have experienced burnout and trauma at never seen before levels. And there was very little infrastructure in many places to support the emotional and psychological well-being of clinicians and the public. So mental health supports and services must be embedded within the larger healthcare system and within a public health structure to grow population level awareness, support, and recovery. So when we think of the traditional public workforce, we tend to think of things like primary care physicians, nurses, social workers, city and county health officials, and even volunteers. Community health workers are also thought of as part of the public health workforce as they provide education and awareness to individuals living with chronic conditions. However, other behavioral health, what I call allied health professions, many times known as paraprofessionals, must also be considered capable of carrying out public workforce objectives. So who are these allied health professions? Peer support workers, youth peer supporters, and promotoras all do outreach directly to and support individuals in community, especially community who trust them, and they help engage those who may not otherwise participate in formal health seeking or health education and treatment or support activities. They also reflect the cultural, racial, ethnic, and linguistic background of communities more than the professional behavioral health workforce, which is really very racially homogenous in the US. The mental health and both mental health and mental illness were thought about by public health agencies as an afterthought during COVID-19. And it demonstrates how important it is to highlight the work of this allied health professional workforce and how they might be incorporated into city, county, and state plans. So our speakers today are Dr. Vikram Patel, who's a professor in the Department of Global Health and Social Medicine at Harvard Medical School, and Gloria Leva, who's a promotora for the Los Angeles County Department of Mental Health, Vale Smith, who's a peer support specialist and instructor and mentor for the US Marine Corps, and Yesenia, let me see if I've got her name right. You know, this always can happen, right? We also have, where's her name? Yesenia Anaya, who's a lived experience leader for Foster Care Club. So why don't I go ahead and just dive into the questions, and I'll start with Dr. Patel, if that's okay. You ready? Okay, good. So, and I call you Vikram, and I hope that's okay. So, Dr. Patel Vikram, can we discuss the design of the Empower program in Texas, which you've also implemented in India, that embeds mental health care into community with the help of community health workers, and describe how policy and financing might help this model grow to a majority of jurisdictions across the United States?
Thank you so much, Karis. This is such an important subject, and I'm really grateful for being given the opportunity to serve on this panel. Karis, we've talked a lot about the pandemic, but let's be honest. Even before the pandemic, the needs for care for persons with mental health problems remain largely unmet in all countries of the world, including here in the US, in spite of the US enjoying a very large number of resources compared to other countries. For example, the numbers of mental health professionals the US has and the amount of money the US spends on mental health care. And this testifies to the inadequacy of the current approaches to mental health care and the complete unsuitability for the rising demand in the last 2 years. At the heart of the inadequacy of the current approach is a very narrow biomedical perspective on how one addresses mental health problems. And that typically leads to the assumption that one has to be a highly trained and expensive specialist mental health provider to do so. One of the results of this crisis has been the tremendous barrier in accessing psychosocial interventions. Psychosocial interventions are key to the recovery process for virtually all mental health problems. And they're in fact also the interventions that are most preferred by people with a mental health problem. And yet the irony is that the vast majority of people, when they seek care, are only likely to receive a medication. Empower is a program of Harvard Medical School that seeks to address this gap by building on 3 strands of science. Clinical science, which demonstrates the effectiveness of brief psychosocial interventions. Implementation science, which demonstrates how such interventions or treatments can be delivered effectively by non-specialist providers, such as community health workers, nurses, and peer support workers. And pedagogical or learning science, which demonstrates the effectiveness of digital approaches for training and quality assurance. So what does Empower do? It brings together a suite of digital tools to enable non-specialist providers to learn and master and deliver evidence-based psychosocial treatments with assured quality. We've developed a range of different methodologies, such as how one designs a competency-based digital curriculum, how one assesses competencies remotely, how one can implement measurement-based peer supervision for support and quality assurance, and how one can use data to evaluate the impact of the delivery system. Karis, I'm really excited that over the coming years, thanks to generous support from the Lone Star Prize, we will take our first footsteps in implementing the Empower initiative in Texas in partnership with the Meadows Mental Health Policy Institute and the University of Texas, where we will be delivering a 6-session behavioral activation treatment that was originally designed in India, but subsequently adapted for use in the US through community health workers and other non-specialist providers. In conclusion, what Empower is really seeking to do is to flip the narrative that we often hear, a nihilistic narrative about our communities being pervasively and persistently under-resourced, to how can we leverage the resources that every community in America and around the world possesses, people who care for one another. And in terms of what investments we need, well, we need to flip the investment portfolio from investing at the base of the pyramid of care in the community so that we can reach the last mile. Thank you.
Thank you so much. I was actually sitting here taking notes and, really diving into this fact that we focus so much on the medical side, but not the psychosocial intervention side. And the key thing you said, Dr. Patel, is that the psychosocial interventions are the things that people probably most prefer and can engage and can start to engage in. So thank you so much for sharing about the Empower program and how uniquely we're bringing something from India to the United States. Yes. That's also quite amazing. So I'd like to ask Gloria if a few questions, and Gloria's a promotora in Los Angeles County. So can you talk to us about promotoras? They are specially trained community outreach staff that engage people who may not speak English or as a first language, or have other cultural barriers to engaging in health promotion. So can you describe how you and your coworkers outreach has helped engage people in various non-traditional settings to take help seeking action, including while people were in line waiting for other family members to get like their COVID-19 vaccine?
Okay, hello, thank you. Yeah, I'm a promotora de salud mental, mental health promoter. My passion is to engage the Spanish-speaking Latino community in a conversation about mental health through educational workshops. This is the only way to change the stories that we hear about the mental health stigma in the community. During the pandemic, many people were suffering alone. When the pandemic started, we did not think we will be able to continue with the workshops. It was like a kind of a scary time, you know. A lot of people were being serving before the pandemic, and then the pandemic came, and now what we're gonna do? You know, it's like we were worried about because we know our community needs our help. So, but when we help, with help and practice, we learn how to use the computers platforms and do them virtually. Before, you know, I just used one platform and that was it. But now how we're gonna bring the information to the families directly to them? It was very hard time, but at the same time, you know, we would like to continue doing that. So all the promotoras called past programs after we learn how to use the platforms. All the promotoras called the past programs participants, and we learned together how to connect together. Nobody knew about it. So the word started to spread in the community, and people started calling us. More and more people started connecting and looking for our workshops. We were able to reach more people than when we were in person. We had people who were positive for COVID-19 connected. They were isolated and scared. They connect and to our workshops, and you know, share the situation they're going through, and it was amazing to see everyone support that person. Before the pandemic, the program was averaging like 600 workshops per month. By March 2022, we had 913 workshops. So it's a lot more. We started helping the vaccine clinics. We went around and gave out the flyers days before the vaccine started. When people were in line to get the vaccine, they were still scared. Through partnerships between DMH and UCLA, promotoras were trained about vaccines before it rolled out, way before, you know, like preparing us to be ready and go to the community and explain them. So this information helped me understand and reassure people that it was going to be okay to get the vaccines. Some people were in line and wanting to leave and not to get the vaccine, but with our support, they went in and got it. They came out and they found us and thanked us for the support. You know, that was amazing because we were talking and they keep in line until they went and get the vaccine. And when they get offered the vaccine, they say, hey, I did it. You know, I made it. Thank you. And now I have to wait for the reaction. And I say, everything is going to be fine. You know, that's the connection the promotoras and the community have. That connection, like give that, you know, way to settle down and say, hey, everything is going to be fine. We there to support them. So sometimes family will bring their relatives in, but they were not getting the vaccine. We listening to them and use a culture and language to connect. You know, many ended up getting the vaccine after speaking with us. So listening to our community is very important. Sharing that we too had anxiety about the vaccine, it's also important. Sharing like I did have the COVID-19 and it was so, I went through very difficult time and I don't want to get again the COVID-19, and I vaccinate myself and vaccinate my daughter. You know, my daughter is she has a disability, and it's important to sometimes me to share with families, you know, what is going through, and having my daughter having a disability and myself having the COVID, and we were vaccinated. That was amazing because a lot of people listened to what I was talking, and a lot of people took the vaccine too. Before the pandemic, we did our workshops at schools, senior centers, churches, and parks. During the pandemic, many of our workshops were for family homes, for a group of neighborhoods or friends that all connected virtually. Right, you know, I asked my neighbors, and you know, can we do this and this, and they connected by the phone. And you know, some people didn't know how to connect by the phone too, and I was step by step letting them know, you know, this is the way we can connect, and we did it. And so I think it's important to invest in programs like the Promotoras and any other programs to help the community to be aware of the services near them. And the services are there for them, and the importance to create a community free of stigma and discrimination. I think this is the whole point for us as a promotoras, going out in the community and let them know, you know, whatever our parents teach in our homes, we have to get up from that circle and find the little tiny space where to go out and learn to be free of that stigma, free of that discrimination and things like that. So thank you very much. And this is what I can bring to my community.
Thank you so much, you and the other promotoras in Los Angeles County. And again, like, here's the thing that I really love taking away is that by sharing a bit of your own story, and sometimes, you know, licensed providers, they don't know, or they're not supposed to be sharing much of their own story, but for promotoras, community health workers, and peers, that's integral to who we are and what we do and how we do it, and really helps people connect in, because now it's like, oh, well, you're just like me. You're not any different. And that really is very helpful. And that you help people get connected to technology. Technology had to be used for telehealth. How are they going to do it if they don't know how to use it? So, wow, thank you so much for your work in Los Angeles County.
Thank you.
So I also have questions for Vale. Vale, as a volunteer and a key part of the public health workforce and a person with lived experience who most recently testified for the House Energy and Commerce Committee, why do you think it's important for peer specialist training programs, such as those through the Veterans Administration or HRSA's Behavioral Health Workforce Education and Training Program, or BWET, program, to be invested in, and for peer specialists to be a part of the public health workforce?
First thing I'd like to say, it's important to be invested in because it's dealing with human lives. And each human life is valuable. I know a lot of patients that I deal with, or individuals, forgo treatment because they have some type of issue with a mental health professional. It might be feeling uncomfortable. It might be stigma. It might be a bad experience. And, you know, these mental health professionals are highly trained, and they need, I would say, the individual needs the care that they can provide, but there's a bridge in between. And so to cross this bridge, that's where the peer support comes in. I work with peers at a lot of VAs around Illinois and also around the country, and I work with a lot of different individuals. The consistent problem that we're having is not enough peers, and we don't have enough peers, and that leaves a lot of people to fall between the cracks. And when they fall between the cracks, it can lead to like dire circumstances such as HRSI. If peers, we bridge that gap. And some things that an individual might come in, he might not feel comfortable telling a doctor or a psychiatrist or a social worker. He will feel comfortable telling us. We in tandem work with the team, and we can relay these concerns. You know, empathy is empathy in my lived experience are the biggest things that I use in my position. And when you can touch someone and you can feel what they've been through and they know that you've been through it, it's easier for them to relate to you. And when they relate to these issues, it creates a bond, and that bond becomes something that they can, come to you any time of the day. They can call, or they can, I don't know, they can just get help that they can't get otherwise. I know for me, I've been in situations where the police have called me. They've called me to talk to an individual because he said, I like to talk to Val. And I've been on the phone with him. I felt, out of sorts doing it at first, but as it became, it's just another peer. And I told them I've been through so much in my own life. I've been through, I've had SI. I have depression. I have PTSD. I have a couple issues of my own. And I can relate my story to them, and it lets them see that there is maybe a light at the end of the tunnel when they see me acting in my position as a peer. Otherwise they have no hope. And hope is a big thing that peers instill in other people. I think peers are especially important at the VA and other hospitals around the U.S. because they do give that extra aid to doctors. And when peers become bogged down, right now there are not enough peers in the United States, not enough peers in any city that I know of, and the peers that are there, they're overloaded. And I talk to a lot of peers, and they can't get to individuals quick enough. And when they can't do that, it leaves people out in the cold. Also, you got to realize that the peer is a person who's experienced mental health issues or substance misuse issues himself. And so if they become overloaded, then they themselves might fall. For example, 2.5 years ago, when COVID first started, I overloaded. A lot of my guys committed suicide, some overdosed, and I took it personally. And I didn't have that. I didn't have that person to talk to that I could relate to. So it just became too heavy on me. So I guess I'm trying to say our lived experience opens the door as individuals that we get to learn more than just the superficial things that they might tell a doctor because they're afraid to, or they're nervous. Our presence alone just it opens the door to a person's inner problems and issues. And when they see that we have been through the same thing, it enables them to see a way out of whatever they're going through. I guess that's all I got.
Great. So let's turn and ask a question to Yesenia. So Yesenia, as a peer leader who has provided support to current and former foster youth with Foster Club, the National Network for Youth in Foster Care, both virtually and in person, can you share why it's important for peer support to be available for young people in or from foster care? What's needed to increase the access to quality peer support for young people in foster care?
Yeah, first off, I'd love to just say that I'm extremely grateful that this question is finally being asked. I would kind of like to start off by responding and sharing a little bit of my experience in foster care, and then I can speak a little bit how Foster Club has created such an amazing dynamic and environment that is just like super needed to help with this access to peer support. I believe, like many children who get Child Protective Services called, it's not their first time when that final call is made or that final visit is had. And usually it's a call to the school. So, and every time, I just remember every time that I'd be called to a principal's office or to the office, it feels very different. Like they don't even have to say that this is that type of call, that this is that type of, call to the office, but you just feel it, that this is different. You know exactly what it is, you know exactly who's showing up. And I remember the last time that this happened for me, I was sitting at my computer, I was doing a project, and my guidance counselor, who I was very close with, and I talked to every single day about the problems that I was having at home came to get me. I just knew that this one was different. So even though I knew this, and even though I was, mentally preparing myself for what I was about to walk into when I went into the office, it just never really prepares you or actually prepares you for those, for that immediate feeling of terror, confusion, and this loneliness too that comes with hearing words about that you're not going to go home or you're not going to see your mom, and that when you ask, I remember asking, hey, where is my mom at least? If you're telling me I'm not going to go home to my mom, where is she at least? And I was told that they cannot tell me that information. I remember kind of demanding, no, I need to know where my mom was. And I was just denied and denied and denied. I think that if I would have just been told, that information, or just at least let me know that my mom was okay, it would have helped me a lot. I went from, dedicating already a majority of my life to making sure that this person was safe and alive and okay with, very dangerous, a very dangerous environment at home, to not knowing her whereabouts at all. And this really hurt me. This went into some more answers being denied of me. And of course, I was in tears. I told the social workers that I would collect my own things from my locker. They had offered to go do it for me. And I said, no, I can do this. I actually was so adamant about going to get my own things because desperately, I just wanted to wait until that bell rang to let all of my friends out of class. I knew that it was a couple minutes away. I had two really close friends that had kind of tough home experiences, and also was aware of what was going on in my own home life. And I just so desperately wanted their love and support, even if it was just for a minute, even if it was just for, a quick group hug, just something. And I never got that. I was rushed down the stairs out of the door. I tried over and over and over again to plead with them and let them know that, if I could just stay back a few more minutes and get that support from my friends, that I would feel a lot better. And I was just hushed and made to feel like asking what I needed was wrong or out of line. This is just one of many times that myself or a member of my family needed support and was denied of it. This kind of denial to be heard instills a kind of damaging behavior that ends in self-destruction and not being able to ask or know how or when to ask for help. At 24 years old, I'm still learning how to do this. I ran myself into straight up mental illness and exhaustion, trying to power through everything alone and ignoring that my mental health was severely neglected. This next part may be a little bit triggering, so I just want to warn of that. I ignored my mental health so bad to a point of a suicide attempt. Thankfully, I was admitted into a hospital, and 2 weeks after my discharge from that hospital, I flew out to Seaside, Oregon, and I started my internship with Foster Club. I went in completely oblivious on what to expect, but this is where I was greeted by a plethora of peers for the first time, that I was surrounded by people who had already been through traumatic situations in their past and was trying to just navigate adulthood like I was for the first time or for a while. And also adults that were trained already on how to deal with situations or outbursts from us when we're trying to navigate all of these emotions. It was this weird connection, not weird, but just special connection between all of us that made you feel so safe and not alone. We were taught how to deal with our trauma. We were taught how that trauma affects us internally and mentally. And this is something that needs to be had all over the place. This needs to be had and taught in classrooms with social workers. It needs to be shown that when a child is telling you what they need to be heard. They need to be surrounded by peers. Peer support is so crucial to mental health and to knowing that you're allowed to ask for support and you're allowed to surround yourself with people who understand. Thank you.
Okay, well, thank you to all the panelists and for such a rich discussion. And by the way, I don't know if I introduced myself, but I'm Karis Myrick. Hello. And I was just your facilitator for today. So I really appreciate having this panel. Very, very powerful discussion. Thank you to all of the panelists.
Welcome back, and thanks, Karis, for helping paint a picture of how public health agencies and health systems can consider building up a workforce that's racially, ethnically, and linguistically responsive and diverse as mental health needs continue to increase, especially in youth and young adults. My colleague Sydney Daniello is here with me and has joined to help us introduce our next speaker. Sydney, how are you enjoying the program, and what do we have to look forward to next?
Well, it's been an honor to hear from such knowledgeable experts in the fields of public and mental health, and to learn more about the critical efforts toward prevention and creating a more equitable and inclusive mental health workforce. I'm really looking forward to the rest of the program. And now I have the pleasure of introducing our next speaker, Catherine Delgado, who is going to share with us her work and experiences advocating for student mental health and wellness and amplifying youth voices at the local level. Catherine is a current student at George Washington University and a member of MHA's Young Mental Health Leaders Council. She's the co-founder of the Student Wellness, Education, and Resources Committee, or SWARE Committee, at the San Diego Unified School District. SWARE is a student-created and student-led mental health advocacy group about which Catherine will be sharing more with us today. After we hear from Catherine, we'll take a quick 5-minute break. And with that, I will turn it over to Catherine Delgado.
Hi everyone, I'm Catherine, and as I was growing up, I watched those closest to me struggle with their overwhelming stress, anxiety, and desire to self-harm. Even more so as schools started to transition to online learning in 2020, it felt as though our schools were abandoning their students when they needed them the most, when they were experiencing extreme isolation and mental strain. And I was observing that there were students like me in other high schools within my school district who wanted to make a change, but didn't really connect with each other yet. So with my friend Hannah, we co-founded the Student Wellness, Education, and Resources Committee, or the SWARE Committee. SWARE is a student-led mental health advocacy group within the San Diego Unified School District, which is also the second largest school district in the state of California. And we created this committee to connect youth advocates together and empower the youth voice, and also bridge the gap between school campuses, but also between students and leaders within our school district. And the way SWARE works is we provide 2 representative positions to all high schools within San Diego Unified, and at their individual high school campuses, they organize their schools and create mental health clubs. And then the representatives also meet twice a month as a committee to share their efforts and their initiatives with other school campuses, and also organize together to be a coalition and a leading force to champion student mental health within the district. And we advocate for many different policies in favor of students. So some of those being excused mental health absences, creating what I wish my parents knew forms for the district, and implementing youth mental health first aid training for teachers within San Diego Unified. SWARE's biggest achievement, though, is our mental health curriculum. So our founders believed that integrating mental health and wellness within the everyday curriculum was necessary to providing students with the life skills and the resources they needed to lead happy, healthy, and productive lives. So with the help of the student board member, Zachary Patterson, former president of the board, Richard Barrera, and our former superintendent, Cindy Martin, who is now the Deputy Secretary of Education for the Biden administration, we unanimously passed a resolution to implement comprehensive and research-based mental health curriculum in all secondary high schools within the San Diego Unified School District. And in the summer following the passing of the resolution, I helped design the curriculum along with some other students from SWARE, district employees who have experience in writing curriculum, and experts in the mental health field from organizations such as the JED Foundation, UC San Diego, and Rady Children's Hospital. And we created a whole curriculum with lesson plans that lasted about 15 to 30 minutes long, focusing on 5 topics, which are 1, wellness education, which focused on internal coping; 2, mental health education. So what is mental health and why is it important? 3, recognizing early signs that precede mental illness. 4, mental health resources. So knowing when and how to seek help. And 5, allyship and leadership. So that's advocating for others and building trusted relationships with those you care about and with trusted adults. And now the curriculum is set to be implemented in middle and high schools within the school district in the fall of 2020. But the biggest challenges that SWARE has been facing is actually with the implementation of the curriculum that we designed. So since moving from the design to the implementation phase, the curriculum has been slow to actually be taught within high schools and middle schools within our district. And it seems as though on the district side with their employees that there's been a lack of a follow through, communication, and recognition towards SWARE and our work. And this is really discouraging to see because SWARE was founded to empower the youth voice. And even though we've been organized for 2 school years already, the struggles and the lack of support that we're feeling still continues, even so. So SWARE has created 3 action items and demands that we ask for from the school district. Those being communicate existing mental health resources, represent student advocacy groups at the district level, and implement calendarized mental health minimum days into the school schedule. So at SWARE, we believe that the students who compose our committee are the most dedicated, passionate, and driven mental health champions and youth leaders within the city of San Diego, and we remain committed to empowering their voices. So moving forward, we hope that the SWARE committee can serve as a model for other communities and how youth can organize and fight for the causes that they believe in, particularly mental health. And I hope that this was helpful to you and other youth across the nation, and that SWARE can help in your advocacies. So thank you.
And now we have a message from Assistant Secretary for Health, Admiral Rachel Levine, who is a former state public health commissioner. And in addition to her recent posts in medicine and government, she's an accomplished speaker and author of numerous publications on the opioid crisis, adolescent medicine, eating disorders, and LGBTQ medicine. She'll be followed by Mighty Fine of the American Public Health Association, who appears in a short video on the relationship between public health and mental health, and then provide some remarks just for MHA.
Good afternoon. I am delighted to join you today for your 2022 National Policy Institute. I want to thank all of the public health and mental health providers, your staff, and by extension your families for the very difficult work you've been doing for more than 2 years, supporting the American people through the COVID-19 pandemic. You have my personal gratitude and that of the entire United States Department of Health and Human Services. COVID-19 has been by far the biggest public health challenge our nation and the world has seen in more than 100 years. It has impacted our health, our families, our schools, our businesses, our healthcare system, and local, state, and federal government. One important lesson of the pandemic is that we are all truly interconnected, and we need to ensure that a healthier future includes eliminating health disparities and promoting health equity. An area of interconnection that I would like to emphasize is mental health and public health. I have experience in this area, first as the Physician General and then as the Secretary of Health for Pennsylvania, and now I am bringing that expertise to my role as the Assistant Secretary for Health, building off methods that I used at the state level, such as prevention efforts, opioid stewardship, such as educating medical students and medical professionals, rescue efforts with the life-saving medicine naloxone, and expanding treatment, particularly medication for opioid use disorder. Our country faces an unprecedented mental health crisis among people of all ages and backgrounds. Communities of color are disproportionately undertreated, even as their burden of mental illness has continued to rise. Even before the pandemic, rates of depression and anxiety were increasing. And the grief, trauma, and physical isolation of the last 2 years have driven Americans to the breaking point. With the nation's mental health and substance use disorder needs squarely in focus, last year Secretary Becerra established a new Behavioral Health Coordinating Council, or the BHCC. The Assistant Secretary for Mental Health and Substance Use, Dr. Miriam Delphin-Rittman, and I serve as the co-chairs for this coordinating body, which is composed of senior leadership from across the department. This is a great example of how the department is bringing public health and mental health together. The BHCC's primary goal is to facilitate collaborative, innovative, transparent, equitable, and action-oriented approaches to addressing the HHS behavioral health agenda. We are now at a pivotal point in transforming behavioral health care. At the State of the Union on March 1st, 2022, President Biden announced a bold vision to prevent and treat mental health and substance use disorders. At HHS, we are bringing together public health and mental health to implement this vision for health transformation. We are looking to integrate the full spectrum of behavioral health care into healthcare services, social services, and early childhood systems to ensure all people have equitable access to evidence-based, culturally appropriate, person-centered care. We must ensure that public health authorities have the resources, workforce, and IT capabilities that are needed to protect the health of people in the United States and worldwide. When we discuss capacity building for and preparedness of the healthcare workforce, considerations for services to support mental well-being cannot be overlooked. Increasing mental health services with particular focus on the adequate number of personnel and ensuring required professional skills are areas of great need. A strong focus on community mental health programs and integration with primary care clinics and community services is key to reaching a larger portion of populations in eliminating inequalities. It is important to highlight the need for communication strategies that convey culturally relevant, accessible, and evidence-based information on mental health. Communication approaches that leverage research findings help facilitate greater understanding of mental health prevention and treatment, including the continuum of care of mental health wellness, and they are necessary for optimal global mental health outcomes. In addition to a whole-of-society approach to promote, protect, and care for mental health, the dedication of our behavioral and public health workers has shown through during this pandemic. My message today is that it is important to remember your own mental health. Realize when you need a break and when you're giving too much of it. You can only help others if you are healthy too. Please remember to take care of yourselves and always stay connected, stay informed, and stay safe.
Hi, my name is Mighty Fines. I'm an expert with the American Public Health Association, and today we're going to talk about public health. Let's say someone is diagnosed with heart disease. Their doctor prescribes some changes to their diet and exercise, and maybe even medication. And over time, they get healthier. Our hypothetical heart patient is doing great now, but they could have been one of the 655,000 Americans who die of heart disease every year, according to a 2020 report from the American Heart Association, which is a lot of people our healthcare system needs to care for, and that's just one disease. So instead of treating people individually after they get sick, ideally, we just keep everyone healthy in the first place. That's where public health comes in. Public health can be tricky to define, partly because so many factors influence health. In ancient cities, public health interventions focused on sanitation, but also city planning. Over time, public health started targeting specific groups of people like factory workers. In industrial era Great Britain in the 19th century, years of protesting led to better working conditions and fewer workplace deaths. Those were public health efforts too. These days, public health efforts often focus on addressing the systemic inequities that impact health, which are the differences in things like where we're born, where we work, and where we live that determine our access to the resources we need to be our healthiest selves, like safe drinking water and reliable healthcare. Research based on U.S. Census data from 2010 through 2015 shows that people living without these resources can die up to 20 years earlier than people living just a short distance away. Studies like this are an example of public health's population-based approach, which focuses on societies as a whole rather than individuals. A population-based approach can be used to inform educators, policymakers, and community leaders, all of whom play different roles in improving the health of the community. And like that census study showed, health issues aren't caused by any one thing, so they can't be tackled by any one solution. Take automobile safety. From 1979 to 2011, motor vehicle crashes in the US decreased by more than 41%, which took a variety of strategies, like increased education, stricter laws around seatbelts and speeding, and improved design and use of child car seats. It wasn't a single strategy or solution, but multiple players working together to address the same issue from different angles, which is important because our societies don't treat people equally and different people have different needs. And the best interventions don't just focus on the present. Public health experts call this an upstream focus. Instead of just focusing on the issue and the problems it causes downstream, we look back upstream at the causes of potential health issues and how to prevent them. Like tobacco use. Despite several downstream measures to get people to stop using tobacco, from increased taxes on tobacco products to images of diseased organs on cigarette packaging, it remains a leading cause of death in the US, which is why intervening upstream in preventing tobacco use is so important. Prevention could look like state-mandated school materials on the health impacts of tobacco, or legislation that bars tobacco companies from advertising to children or communities with high rates of tobacco use. The goal is to prepare future generations to choose and maintain healthy behaviors. Finally, just like we use a population-based approach and focus on groups of people rather than individuals, effective public health interventions are holistic. which means they treat health as a whole rather than a single aspect. So public health efforts to address heart disease could look like repairing sidewalks or creating parks in an under-resourced community. This would encourage people to get active, improving their physical and mental health. So overall, public health includes all of the organized and holistic efforts to improve policy, education, and access to make the healthiest choice the easiest choice for everyone. If you want to learn more about public health services, check out the Center for Disease Control's 10 Essential Public Health Services Guidelines or the APHA website. Thanks for watching. This video is a part of a series created by Complexly and the American Public Health Association to shed a little light on the important work that public health does. To learn more, visit apha.org. We've witnessed mental health needs rise drastically during the COVID-19 pandemic. Data shows increased anxiety, depression, suicidal ideation, trauma, PTSD, among other impacts to our mental well-being. As needs rose, hotlines and warm lines across the country saw increased call volumes as well. And we knew there was a dire need to address mental health and mental illness in our communities prior to the pandemic. As I just stated, it had a direct impact on our mental health, physical health too, of course, yet it further highlighted the urgency for us to act. As we think about how to bring together or further cement the relationship between mental health and public health, I'd just like to emphasize that public health focuses on population and community level health rather than the individual. We still take into account individual level factors and contributors, but the focus is on the collective. Determinants of health, which are the conditions and the environments where people are born, live, learn, work, play, worship, and age that affect a wide range of health, functioning, and quality of life outcomes. We see this at play in the United States, of course, and globally as well. Some of the social determinants of health include, but are not limited to, safe housing, racism, discrimination, bigotry, violence, education, employment, income, access to nutritious foods and physical activity, the availability of green spaces, language and literacy skills. And when we see the confluence of multiple social determinants of health at play in our neighborhoods, we classify this as concentrated disadvantage. And these are all areas that have to stay on top of mind as we become more intentional about this bi-directional approach, as we know these challenges have a direct impact on mental health and mental illness. At the American Public Health Association, we have a vision to create the healthiest nation in one generation. And we know we cannot achieve this without addressing the mental health needs of our communities, which we certainly includes the needs of our healthcare workforce, who in addition to frontline workers, experience burnout and trauma at unprecedented levels during this pandemic. And of course, we must take action to address the workforce, whether that's burnout, shortages, and ensure that they are supported in the ways they need. So I've talked about the public health approach, partnerships, the workforce, which are all critical pieces of this bi-directional puzzle. And in closing, I want to briefly talk about policy and advocacy. In President Biden's federal strategy and through other agency actions, there was a plan to invest billions into community-based mental health services and to address issues impacting the public health and frontline workforce. Congress is also considering comprehensive legislation to reauthorize SAMHSA, CDC, and other federal agencies responsible for the public's mental health, especially in the context of a public health emergency like COVID. Congress already enacted the Dr. Lorna Breen Act to facilitate education and support for healthcare workers experiencing trauma and burnout. Obviously, federal leaders should ensure that each investment into public health and the healthcare system do not unknowingly exclude mental health. That coordination needs to happen at the federal level as well. Advocacy for mental health is crucial, especially during the COVID-19 pandemic. And APHA, we continue to urge Congress to make mental health services readily available during the current pandemic, future public health emergencies, and just readily available and comprehensive in general. Related to that, at APHA, our members develop policy statements to help shape APHA's position on legislation and regulations. So I'd like to leave you all with an example of how we support a collective approach to addressing mental health through some action steps outlined in one of our suicide prevention policies. While the focus is on suicide, I believe it is applicable to other aspects of mental health as well. One aspect of the policy focused on the expansion of infrastructure to support public education and training in suicide prevention, including efforts by national, state, territorial, tribal, and local public health entities. First, it was to educate the general public to recognize and respond to warning signs for suicide through evidence-based gatekeeper training programs and rigorously evaluate widely used gatekeeper training programs to ensure their efficacy. Two, develop and implement strategic, culturally relevant public health messaging campaigns that promote hope and healing. Three, educate and collaborate with local news media to ensure that the news coverage about suicide adheres to best practices regarding reporting on suicides. Four, engage employers, labor unions, and community-based worker organizations to implement and develop training programs and model policies for workplace suicide prevention programs. And the fifth and last is to engage community partners in a comprehensive public health approach to suicide. Community partners include but are not limited to faith leaders, schools, and community organizations that serve Indigenous populations, active and retired military population, firearm retailers and firing range owners, individuals with lived experience, youth who identify as LGBTQ, and Black youth. Again, this is just a demonstration of how we engage in this bi-directional approach, bringing all folks to the table. Mental health and wellness have received more attention during the COVID-19 pandemic, and we need to tap into this momentum to ensure that mental health needs are being addressed with intention and accountability. It's not just about the absence of these adverse impacts to our mental health, it's also about the presence of opportunities, facilitators, and support to help us all reach self-actualization. So with that, APHAs look forward to working alongside Mental Health America and other organizations to demonstrate the power and the potential of our collective efforts in this space. Thank you.
Hi, and welcome back, everyone. Thank you so much for that comprehensive talk about public health, Mighty. As noted, we have a mental health crisis among our public health workforce, our mental health care workforce, and there are a majority of nurses, physicians, medical students, and public health workers reporting symptoms of burnout and at least one mental health condition, according to Department of Labor data. Mental Health America encourages employers to go beyond the usual employee assistance programs and develop employee-informed supports for a mentally healthy workplace. The MHA Bell Seal certification provides a rubric and assessment system for employers to support mental health. And we also have other workplace programs, including a survey that assesses from year to year whether or not people are feeling mentally healthy at work. The Surgeon General's May 23rd advisory on frontline worker burnout and resignation also has recommendations to support employee mental health, including efforts to reduce administrative burdens to help health workers have productive time with patients, communities, and colleagues, and increase investment in the public health workforce. Raina Taylor, Vice President for Public Policy at the National Council for Wellbeing, knows a lot more about this issue. So I'm very pleased to turn it over to Raina as she will lead the next panel of experts in a discussion about systems and structural changes that may be considered by decision makers to support total worker health. Before we hear from Raina, however, we are just about ready, I think, for the live speakers to go, but we may need 1 or 2 minutes to get everyone.
Hi, everyone, and welcome back to the Mental Health America Policy Institute. As Karen said, I'm Raina Taylor, the Vice President of Public Policy and Advocacy for the National Council for Mental Wellbeing. And thank you all for being here. As Karen said, she's spot on. So have all the speakers been today. We have been in a national workforce crisis shortage for years prior to COVID-19 and the pandemic. But the pandemic has shown us that we must strengthen our system, we must take care of our healthcare workforce, and we must be able to move forward with systemic change to have that happen. So here with us today is our esteemed panel. Let me introduce you to them. So our panelists here are Jean Alongi from the National Association of Chronic Disease and Disorders, Lorena Roth from the National Mental Health and Wellness at Kaiser, Liliana Bador from the Association of State and Territorial Health Officials, and Dr. Arpan Wagri from HA Behavioral Health Chair from the Providence Health System. So what we're here today to discuss is systemic change and what needs to be done to increase the well-being and take care of the healthcare workforce we have. As we know, there has been a shortage. We have seen from recent data in HRSA and the Kaiser Family Foundation, almost 150 million people live with mental health and live in mental health professional shortage areas, and the demand for services have increased, a lot of these being our own providers. So how do we go about taking care of them? Let's start with you, Jean, if you don't mind. I want to know, what do you think is the connection between public health and chronic disease prevention? What would you suggest policymakers consider in future legislation to protect and help our workforce?
Thanks so much, Raina, and hi, everybody. It's really a pleasure for me to be here today. Let me clarify, I am with the National Association of Chronic Disease Directors, which is an ASTO affiliate and a membership organization of all 50 states, DC, and 8 territories, and their chronic disease prevention activities. My pronouns are she, her. I really appreciate this question. The last 2.5 years have hit public health hard, just as it has mental health and the healthcare fields. For public health, we're seeing that impact in increases in chronic disease morbidity and mortality, and to the public health workforce, as you've been hearing about today. In terms of chronic disease prevention and control, we saw a sudden and dramatic slowdown both in intervention delivery as state and local health departments and their community partners waded through those first months of lockdown and figuring out how to work remotely. That many of us were facing, but these are systems that historically didn't accommodate remote work. So trying to figure out just the system for keeping things afloat was a challenge. We also saw shifts in health behaviors in the general population. So things like tobacco use, physical activity, care seeking for clinical preventive services and chronic disease treatment. All of that conspired to create a COVID-related health debt. And we define that as the accumulated impact of changes in health behaviors during the pandemic that will have long-term negative effects on health. Just this week, there was released from the National Bureau of Economic Research a report that looked at what's been happening in health since the pandemic. And they found that from April 2020 through the end of 2021, Americans died from non-COVID causes at an average annual rate in excess of previous trends. So more people are dying of heart disease, hypertension, and diabetes, obesity, drug-induced causes, and alcohol-induced causes elevated above the previous COVID numbers. And the kicker here is that trend isn't slowing as other COVID impacts slow. This is still continuing to worsen. So we're very concerned about this health debt. At the same time, most of the public sector chronic disease prevention workforce has been deployed to pandemic response, either full or part-time, often on top of their usual roles, and worrying about not meeting their chronic disease prevention grant deliverables and possibly losing their funding. So as you can imagine, lots of burnout, lots of turnover, lots of worry and trauma. The de Beaumont Foundation estimates that there's an 80,000 person deficit in the public health workforce. That's probably an underestimate. That's based on some work done before the pandemic. And we've seen, like I said, lots of turnover. We've also seen the blessing and the curse of large influxes of funding in recent months. It's a blessing because we need it. We need more workforce in public health. There's been a historical underinvestment. But the curse is the quickness with which this money needs to be spent and some unintended consequences of recruiting folks away from health departments, putting them in jobs that don't have the stability that they need. So this is going to create some problems down the road for that workforce. What I think our policy opportunities are to make sure that we've got a good investment in primary prevention that includes mental health. This isn't the last pandemic that we're going to see. We saw folks who had chronic disease and mental health issues suffer more from COVID in this go around. I can imagine that is going to be the same in the next pandemic. So making sure that we are helping people be as healthy as they possibly can on an ongoing basis. And we need primary prevention for that. And then investing in long-term public health infrastructure that has a longer time horizon, that isn't trying to get money spent in a 12-month cycle. That would be my dream. That would be my dream.
Well, thank you for that, Jean. And yes, I think all of us want to see that systemic change happen. Absolutely. You know, it reminds me now, and I'm going to turn to Liliana around the co-authored report from CDC that was published recently on the mental health needs of the workforce, or the health workforce, and the HEROES program that you've used to kind of grow workforce resiliency. Can we discuss the HEROES program for a minute, and sort of what the results would be or what are expected from the program, and then any federal policies that could help fuel that upstream approach and support our workforce?
Sure. Thanks, Rena. Yes, I'm so excited to talk about this opportunity because it's a unique one that really addresses this head on. We've not really been able to address this in ways that we are now. The Public Health HEROES program, of course, you got to get an acronym. It stands for Public Health, Hope, Equity, Resilience, Opportunity Program. I'd love to talk about it for just a minute as we're really kicking it off. So, of course, you've heard the context probably all morning about the majority of public health workers being affected by these mental health conditions. And we know it's not the last. We know it's not going away. Let's support them. So with inadequate staffing from before COVID and certainly with COVID as well, there's also emotionally draining work, there's poor communication, there's less communication with colleagues, and these mental health symptoms have been linked with higher turnover, increased absenteeism, lower productivity, morale, all ultimately, resulting in lower public health agency effectiveness. This is our infrastructure. This is what we need to really make sure that we have and support. So the Public Health HERO program for state and territorial health departments is all about creating and supporting a culture of well-being and resilience. And it uses evidence, a trauma-informed approach, it's critical to this, and an equity framework. So let me just take a minute to walk you through the 5 components of this program and what we hope to achieve after. So first of all, we're doing a scan of existing successful practices among health departments, approaches, resources. We're coupling it with a needs assessment to identify what health departments want, need, their capacity and readiness to address burnout and moral injury. Number 2 is we are going to build a publicly available website of resources that we collect and connect people to. And number 3, we will offer virtual learning opportunities, not just to health departments, but to our partners who can support this. We will be providing coaching and technical assistance to 5 pilot sites to really dig in. And then, of course, any good program comes with evaluation and improvement, right? So we're going to improve on the package of resources. And what are we trying to do? Well, it's all about increasing and strengthening policies and practices that would reduce burnout and moral injury. We want to see revised and strengthened policies throughout, the little p and the big P in terms of policy, and promote workforce well-being, provide those resources to the organization, but also for self-care, and ultimately increase retention and capacity to serve in these areas. So right now, I will get to your second question now, if we want to go to the federal policy's impact. Like others have said already, public health is underfunded, undervalued, and we really urge legislators to support innovative programs and strategies and do it with funding and time to provide long-term investments in not just state, but federal and local and territorial health departments as well, to address these workforce shortfalls like infrastructure, health equity, and data modernization. So my last thing I'll just say is to protect and optimize, I should say, our foundational health infrastructure. We urge our policymakers to increase funding for public health, including CDC and ASPR, the preparedness and response programming, through annual appropriations bills. And specific cross-cutting programs like that would include the CDC Public Health Emergency Preparedness Cooperative Agreements, their CDC Social Determinants of Health, the CDC Preventive Health and Health Services Block Grant, and ASPR Hospital Preparedness Program. And Rena, I'll stop there, turn it back to you.
No, I think that's great. I mean, the bridges that we're already hearing in terms of the need for reform and help in terms of federal funding and addressing what we need to do to not only strengthen the workforce from the mental well-being side, but also address the social determinants of health that go alongside that. I thank you very much. Lorena, if you don't mind, I'm going to turn to you and sort of ask, the National Academy of Medicine and Public Health Association both acknowledge that supporting the strength, resiliency, and mental health of our public health workforces must go beyond the individual behaviors and instead focus on the leadership of health systems and government. Can you discuss the structural transformation of the work conditions need to shift the burden and lift the burden of burnout and mental illness off employees and clinicians, such as decreasing job demands and changing scheduling practices?
Yeah, thank you so much. I'm so happy to be here. I think one of the things that the pandemic has really shown us and really highlighted is how we're going to be transforming and what our care delivery is going to look like in the future. We went from a primarily office-based care models in a lot of health systems to a virtual model and a hybrid system with very few kind of tools to get folks into their homes to provide care to our patients. And what we've seen is we're going to need to now really come up with some strategies and frameworks to help keep that moving forward into the future, because that is our new reality. We will go forward being a hybrid model. And with that's come some great access for a lot of our patients. It's built in some flexibility for a lot of our providers. But I think that what we didn't anticipate were some of the secondary issues around burnout, around having a real fuzzy line between work, providing care, and being at home. And also for our mental health workforce, going through the pandemic themselves and experiencing the same thing that our patients are experiencing, but having maybe less resources to do that where before they could really lean on their colleagues, they could be connected in ways that really made them feel supported and modeled around self-care. They haven't been able to do that as easily. So really, when we look at structural changes, what are the things that we need to think about for our workforces? How do we keep folks connected and engaged with their peers, with their colleagues, with the support systems that they need in order to continue to provide that care, especially around mental health? I think the stigma of mental health, we see that decreasing. That means a lot more visibility, but a lot more demand. And I think the other highlight really here has been how do we retain our workforce in mental health specifically? Because folks really, they're, like I said, experiencing the same public health issues that their patients are, but with less stability at times. So then they're also leaving the workforce and seeking services for themselves. So some of the things that we're thinking about as far as what's the leadership structure that we can provide, some transformational care qualities that we can really think about and focus on are going to be, how do we keep hybrid models working? How do we support families and our workers in doing the work they want to do in a way that makes sense for them and decreases burnout? So that includes, as it requires retention policies, how do we across state lines allow folks to practice therapy and psychiatry more easily? So do we have state licensing agencies and policies that really support the movement of folks? Because we have seen a lot of movement and migration in the workforce. The other thing we can think about is, as sole providers for mental health, excuse me, that there's a certain burden of carrying all of that emotional trauma with your patients. So how do we then create care teams and collaborative care models? So Don Mordecai spoke about that in the opening. Collaborative care models of care, specifically in primary care, to really support patients where they need to get their care, where they want to get their care, and then providers in really creating teams so that it's not a sole provider that's carrying that for the patient. There's a team that wraps around the patient in those ways. The other piece is looking at how do we create a pipeline for mental health in particular of new folks coming into our mental health care system. We need to make sure that we have really a way in for folks. So how are we training them to do telehealth and hybrid care? How are we supporting them in their own mental health needs? And then how are we building a pipeline so that in the future we can continue to have a robust workforce that really meets the demand that's out there? And really the mismatch in supply and demand has really come to the forefront. And that's really a national emergency when we don't have enough mental health workers to meet the demand out there.
Well, and thank you for that. I mean, that really articulates sort of the supply and demand issue that is going on that creates this sort of workforce tension along with that burnout. But I do want to ask, Arpan, if you don't mind kind of weighing in too on this. And, as the Chief Medical Officer for Providence St. Joseph's Behavioral Health Medicine, you help to oversee a program that supports mental health well-being of employee, clinicians, and caregivers. Can you describe the success of the Providence's program and the different components of support you've provided, including the tools, resources, connections, and how can we then make that expanded through policy and further kind of exemplify this model?
Thank you so much, Raina. And it's such a privilege to be a part of this conversation. There's so many rich thoughts that were shared. Before I get in and describe our journey through Providence, so what I was going to do was walk through what we experienced over the past 2 years and some of the programs we put in place that hopefully can help inform some of the thought leaders on this call in terms of ways in which you can think about policies that promote help-seeking behavior among the healthcare workforce, remove stigmatizing language from places that kind of come in the way for people to get help. But before I get into that, I do want to build a little bit on Lorena's comments and some of what you said earlier, Raina, as well, and quote Christina Maslach and one of my most favorite quotes in which she described, and I think it's really important to set the context. And Christina Maslach said that you don't investigate the personality of a cucumber that's turned into a sour pickle without analyzing the vinegar barrel in which it was submerged. And I want us to sit on that for a minute and think about this, that we create conditions, health systems create conditions that really impact the mental health of our workforce. And so we're not asking people to yoga and meditate their way out of this. What we have to make systemic organizational changes. Now, what we experienced at Providence and walking through our journey on January 20th, 2020, we admitted the first COVID positive patient to one of our hospitals a little north of Seattle, and had to deal with a lot very early on. We could not just recycle wellness offerings from the past and expect that they would meet the current needs. There were different challenges, different needs, and we needed to really think about this. What became clear for us is that the mental health and emotional well-being of our caregivers was no longer just a priority. It had become a precondition for delivering excellence. And we had started off with doing two things. One was we needed to make sure that if any one of our caregivers, so we have 52 hospitals, 120,000 caregivers, and if anyone raised their hand and wanted help for themselves or for their dependents, we needed to make sure we had an intelligent front door that guided them to resources based on their needs and preference. Job number one. Job number two, we recognize that most people who need help in the healthcare world are not going to raise their hand and seek help. So we needed to lean in and proactively support our people to get help. And that's it. And so this entire journey has been around those two things. So we started the first part by partnering with multiple stakeholders, internal and external, and created something called a stress meter, essentially a digital front door that has a very simple way of using the subjective units of distress scale. How are we feeling today? And it could be from okay to stressed, using smiley faces. And based on what people click, resources open up that guide them to what they want, so that based on their needs and preference, they get care. I'll give you an example. A lot of people wanted self-help resources, but they were overwhelmed or underwhelmed by a Google search, right? So we partnered with the group called Credible Mind that was started out of UC Berkeley. And essentially you would come in and say, I want help with parenting during a pandemic, and my preferred medium of learning is, say, a podcast. And you could put those filters in and you get, you're not overwhelmed or underwhelmed. You get high quality information based on what other customers or consumers of that product have used or experts say, to telespiritual health, to computerized cognitive behavioral therapy. And many of us across many health systems have these resources, but we needed to really simplify it and make it easy for people to use and have one front door. This was extremely successful, has been used 40,000 times, brought a lot of help to people, and it's something that we continue to iterate on. Then we recognize that, well, people could be overwhelmed with all this stuff itself, and they might need a phone a friend option. So we created a narrow network of providers who are trained in IPT, CBT, DBT, common modalities of psychotherapy, and we call this the Behavioral Health Concierge Program. So you raise your hand, you have guaranteed same day or next day access to a trained therapist who's focused in brief focus intervention. So this was one part, and again, has been very successful. We've increased the upstream utilization of services by over 100%. Then the proactive leaning in piece had two components. We created a program called No One Cares Alone. And one part of it was to reach out and support the core leaders. Your one up matters the most, and they're stressed. And how do you understand what matters to you, what matters to your team? What are the pebbles in your shoe? What are the boulders? And how do we kind of have very practical interventions that we leave people with? Second was a partnership with the American Foundation for Suicide Prevention. And this was the program that was built out of UCSD, and Christine Motier and team were extraordinarily helpful. But it had three components: normalizing, so a destigmatization campaign. Essentially, this started with our leaders talking about why their mental health to them, thinking about this that in a way that it relates with everyone. And so that was one part. Then using the interactive screening program, an annual mental health checkup. And so we built that into the workflows, and then connecting people to resources. And again, this has been pretty successful, and we're just getting started. So thank you, Reina, for the opportunity, and happy to take any questions or however you would like to proceed.
No, I just want to say thank you all for everything that you have told us today, taught us about what we need to do to make sure that our own healthcare workforce is being taken care of. And in showing us the programs and policies that need to be pushed forward in order to make sure that this is a front and foremost idea that comes to policymakers' minds. And so with that, I want to thank you all for this panel and turn it right back over to Karen for the rest of the program. Thank you all again.
Thank you so much, Raina, and to each of our panelists. We really appreciate you joining us live today. I'm very pleased to turn things over to the next moderator, Mary Giliberti.
Hello, everyone. I'm Mary Giliberti, Chief Public Policy Officer for Mental Health America, and your moderator for this session on prevention, financing, and research. I'm often thinking of that story where we see people in the river drowning, so we're always pulling them out, and somebody finally thinks about, hey, we should go upstream and see why they're falling in. Well, this session is about how do we free up some resources and do some financing to get them moving upstream, and how do we know from research that when they get upstream, they're actually going to be able to keep people from falling into that river. And for today's session, I am joined by two incredible experts, and I'm so excited to have them with us today. We are joined by Dr. Tom Insel. Dr. Insel is a board member of the Steinberg Institute. He is a psychiatrist and neuroscientist by training, and the former director of the National Institute on Mental Health at NIH. He's the co-founder of several mental health tech companies and author of a new book, which I'm sure we're going to talk about, Healing, Our Path from Mental Illness to Mental Health, which I have just finished reading, and I'm anxious to discuss some of the prevention chapter. And he's also the co-founder of MindSight News, which if you're looking for curated mental health news is a great place to go. My other panelist is Dr. Ben Miller, who is the president of Wellbeing Trust. He is a psychologist by training and a policy wonk by profession, co-founder of the Eugene S. Farley Policy Center at the University of Colorado previously, where he was an associate professor. And Ben writes a blog that I also highly recommend, Mental, Fighting the Fragmentation of Mental Health Policy, One Policy at a Time. So I'm delighted to have both Tom and Ben join me today to talk about this topic of prevention. How do we finance it? What do we know about it? And I'm going to start with you, Tom, to just give us a little background. Let's start off with the basics. What do we mean when we talk about prevention in mental health care?
Well, a great place to start. And Mary, what a delight to be here with you and Ben. Looking forward to this conversation. And I hope we can draw you into it as well, because you're quite an expert. I've learned from you over the years about all kinds of things related to prevention. I love the analogy of going upstream. That's kind of what we're talking about here. Generally, when we talk about prevention in healthcare, there are three kinds of prevention that we're talking about. Primary prevention, which is universal. It's like the seat belts or sanitation. That's primary prevention. Secondary prevention is dealing with people who have a risk that's identified but haven't developed the illness. So in that case, you think about exposures for COVID and then giving people, everything you need to kind of make sure that they don't go ahead and get ill. So that's reducing the transition from risk to illness. There's a third kind of prevention, which we call tertiary, which is after somebody develops an illness, doing everything you can to prevent them from becoming disabled. And you can think about these with respect to mental health, because we have all three versions of them in the mental health space. But as you said at the beginning, we may not be paying for them. And so we may not be doing them in the way that we should at scale.
So Ben, why don't you address that? Where are we with public policy right now? Are we paying for these kinds of things that Tom has outlined?
Yeah, this is a great question. And I have to give you my thanks too, Mary. Thanks for having me on. It's great to see you, Tom, again. So I think from an awareness perspective, just pure and simple, we're in a much better place now than we were even 10 years ago. But awareness is one thing, and just highlighting the importance of prevention, it only gets you so far. Most people would agree that there's been this chronic underinvestment in prevention, which includes essential functions like our public health infrastructure, and how this underinvestment has led to increased cost, increased morbidity and mortality. I mean, it's pretty nasty what happens when you don't put the money where you should for prevention. And COVID, if you want to just question that for a second, I mean, COVID has shed a very harsh light on how little we have in place for major issues that impact our entire population. And of course, this includes mental health. So just to kind of put this in perspective, I was looking at a report that Trust for America's Health did recently, and it highlighted how we spend somewhere north of around $3.6 trillion annually on health in the United States. And less than 3% of that is spending directly related to public health and prevention. Now, the last 20 years, we have actually seen a decrease in our spending on things like public health and prevention. And why do I say all this? It's a lot, but why do I say it? Well, I think the same trends that our field has really been pursuing and been lamenting for decades: a lack of funding in community-based services, while downstream are essential in being able to help us achieve population health, don't necessarily let us focus as much on upstream. So policymakers, they use the word a lot. They are using the word a lot more, but the problem for mental health is that the dominant mechanism to get funds into communities for mental health services, the block grant, administered by SAMHSA, only goes towards direct services and can't really be applied to prevention. It's a major limitation that I think we face within our community. Now, while we can use the word prevention and use some of those monies on the substance use block grant side, as a set aside, it's still not necessarily sufficient enough to allow us to do the things that we want to do for mental health. So just quickly in closing here, I mean, to me, this is pretty messed up. Most of our funds should be going towards prevention. If we knew that investing more upstream would help in the long run, why wouldn't we do it? I think that speaks to our biggest challenge today, why we haven't prioritized it with policymakers, why we haven't been able to put this in the forefront of our agenda.
So Tom, let's talk about that investment. So what is the evidence around the investment? So if we make the investment, what does the research tell us we'll get for that investment? Are there programs that have been studied that are evidence-based? Talk to me a little bit about, what the current research is around prevention.
Yeah, it depends on which kind of prevention you're talking about. So let's take a couple of examples. We'll drill in. One that I particularly like, it's NIMH was its origin, so I'm particularly a fan of this one. It goes back about 30 years, nurse-family partnership. So that says, look, if we can provide moms at risk and babies at risk with a nurse who's available for both social support, training, and early childhood issues, helping moms to make that transition, it probably will pay off. Does it pay off? Phenomenally. And what's really fascinating about the nurse-family partnership is it's been around long enough that we can look not only at the outcomes for that mom and that baby, but we can look at the next generation. And there's amazing cascading effect. Cascade is not actually the right word because you amplify the impact in the next generation. I have the numbers, they're not in my head, but they're in the book. Because in the book, I use this as an example where the offspring who received this actually have like a 50% lower rate of substance abuse, 50% lower rate of criminal justice involvement. It's really pretty stunning how big the impact is. I mean, to put it bluntly, if nurse-family partnership were a pill, it would be a blockbuster. That would be like, best pill ever. We don't do it. We tend not to pay for it. We haven't, and now it is available to some 300,000 people this year, but not to 3 million, which is where it should be, because it does work, and we've known that for quite a while. That's on the primary prevention side. There's a lot of work going on now for understanding risk factors for kids who are clinical high risk for psychosis. And there, I think the science is still a work in progress. We don't have enough information yet about what is effective. Well, a lot of what we're doing, and these are more now in the research space, and I don't know that this is quite ready for prime time, is giving intensive cognitive supports to those kids. It makes sense to me because even if they are kids who were not going to go on to develop psychosis, the worst side effect is you've improved their grades and you've given them some cognitive skills that they didn't have before. So I think, that's another place where there's a lot of interest. Let me just give you one final example where I think the data are the best, and that's around intervening for all moms to prevent anxiety, depression, postpartum. There was a review done about a year and a half ago in Nature that looked at that literature for prevention of postpartum depression. And again, the meta-analysis, putting it all together, shows about a 50% reduction by intervening with moms in the second or third trimester to give them supports to make sure they don't go on to develop depression. It works. It's really effective. Hard to get something paid for if you don't have a diagnosis, right? If there's no CPT code, it's kind of hard to bill for it. We can do it in kids with EPSDT, which is a Medicaid benefit that does allow you to bill without a diagnosis, not utilized very often in most states. And it's generally a problem that, as you said at the beginning, Mary, we're paying for people getting pulled out of the water. We're not being paid for all of those things we can do upstream to make sure we don't have a crisis.
Tom, I know that you were involved in many of the studies at NIMH that showed that what we call the duration of untreated illness matters, right? So some of these other programs that do outreach to find people who might be experiencing symptoms but haven't yet been identified, because as you say, you have to be identified to bill for a lot of this. Can you talk a little bit about why it's important to find people early and some of the outreach that can be done to just bring people in, and why it matters that you shrink that duration from when people are first feeling symptoms, but might not be billing or identified yet, but then get treatment?
A lot of that insight about the duration of untreated psychosis came from the RAISE study, which was an NIMH-funded study of how to give sort of comprehensive whole person care for first episode psychosis. When that study was rolling out, we took a close look at what were kids getting before they got a psychotic diagnosis. And one of the surprising factors was that kids had been sick for, on average, I think it was 72 weeks, so a year and a half before they actually got a diagnosis. So we call that the duration of untreated psychosis. In the UK, the standard is 2 weeks duration of untreated psychosis. In the US, we're at about 70 plus weeks. Not good for a couple of reasons. One is a lot of bad things can happen during that period of time. But more than that, the literature is pretty clear that the longer the duration of untreated psychosis, the worse the ultimate outcome for a whole range of reasons. The question is, how do you squeeze that down? How do you get from 72 weeks to 2 weeks? What does it take? And you're quite right, you need to have a detection system in place. It's not going to happen in specialty mental health because they're not in specialty mental health care. They may see a pediatrician, but most often they won't. So where does it happen? Well, you could begin to do this through the school system. And that requires rethinking how you create the resources within the school system to make that the center of gravity for children and youth around mental health issues. A lot of debate about how one does that. In California, I think you know, Mary, we've just put a $4.4 billion plan in place with the idea that we'll create an entirely new workforce, that will actually make schools the center for a lot of this. And one piece of that is to be able to identify very early kids at risk, not only for psychosis, but kids who have been traumatized, kids who have a whole range of problems. The most important thing for people to remember is if we can engage people in care, we actually have good things to offer. We have solutions, but those solutions are useless until somebody's actually engaged in care. So for us, the real challenge is that early detection, getting there way upstream and engaging them before there is a crisis, which is not where you want to end up starting your care.
So Ben, I'm going to let you jump in here too. Let's talk a little bit about other areas where prevention is happening in the US. Are there places that are doing it right? Tom gave us some ideas of what should be done, but you aware of some places that are doing it right, that are working in prevention?
Well, I want to start with just something quite simple, and I really appreciate Tom's framework here because I think there's some opportunities for us to learn from our communities and what they're doing to really embrace prevention that sometimes don't get a lot of airtime. And so I want to talk about that for a second. A couple of years ago, Wellbeing Trust, we partnered with a group called Social Health Labs, and they put out these community micro grants. These were $1,000 to community members, which isn't a lot of money, can't do much with it. But the ideas that came forward to address more of these upstream drivers, some of these issues that could lead to major problems downstream, they were tackling. For example, loneliness, isolation, social disconnectedness, all these things that are pretty significant. I'll give you a couple examples of what they did. There was a 9-year-old in Colorado named Sydney, and she wanted to get kids involved in her local health clinic where her mom worked. And she thought, you know what, how cool would it be if we created a kids club that fostered connection amongst the kids that are just sitting here while mom and dad are getting care, or the kids that are a part of that clinic that know each other in the communities when there's a loss, or someone had a baby, or whatever might happen. And so what they did was they created this kids club and they started making cards. The kids would make the cards. I hope you get better. Congratulations. Sorry for your loss. These were all done by the kids. They were sent to other kids in service of showing support. And I think that's just a simple example of how to really provide a level of support that we would never think about, but it's so far upstream, it actually really matters. Or I'll give you another example. There's a gentleman named Austin who lives in Washington, which gets confusing, but Austin is the name of the guy in Washington State. And he used his money to buy picnic tables. And what he did with those tables is he serves a community dinner every week, 50 some odd people, all in service to bringing folks together and having a conversation. So for me, and this goes back to Tom's point at the beginning, prevention really begins with the recognition that these solutions are inherently social and inherently local. And we can start with things that are far outside of policy and find ways to get our community together, but this has a powerful effect and something that I do think we need to pay attention to. It gives us a sense of purpose and belonging, and these can be protective factors. So let me get back into my space for just a second. Moving away from this for just a bit, we can look at great examples of prevention where we bring care to where people are. Tom mentioned schools just now. I mean, personally, one of the things I'm really enamored with right now are libraries and some of the work that are being done in libraries. Libraries in many places and in many communities are seen more as a community center. It's a gathering place. It's not just where you go for books anymore or access to the internet, though that's important. There's so many great examples in the literature of how to get creative using libraries and mental health for prevention. New York City did Spaces to Thrive, which brought free mental health programming to anyone in the community who wanted it. There was Rowan County, North Carolina, who they offered free online classes to allow folks in that community to get access to how to manage mental health during COVID. These are local solutions led by local leaders. Or what about just bringing clinicians on site, which is happening more regularly now? I mean, I could go on. The point here is that we have to get creative if we're going to be serious about upstream and prevention, and to let those local communities and their ingenuity create new pathways for care. So whatever we do and where we go, we have to really take this life course perspective. As we know, there are so many risks to mental health from the beginning of life, and then of course at different transition points. I mean, I think about my own kids and their youth, and my daughter going into high school next year. And, then there's when you have a family, and there's retirement, and then there's all this other stuff. I mean, we've got to really be looking at all those places, those unique entry points for us to prioritize prevention. I think if we do things like that, Mary, and we lift up some of these local community examples, we'll be in a much better place as a country.
Hey, Ben, we've been covering some of those with Mindsight News. We just did a really cool story about a group, I think they're in Atlanta, African Americans using barbershops as a way to get to men at a place where they are comfortable, where they're engaged, and where they will relate. A lot of this goes back to trust and social connection. And if we keep expecting people to come to us, which is what we do with the $3.6 trillion healthcare system, we're always just going to be pulling people out of the river. Now, if we want to go upstream, it means meeting people where they are. And some of that's actually online, and some of it is in barbershops and community groups and schools and lots of other places that we simply aren't, where we're not. I mean, we're just not there yet. So it does mean, I love the analogy of moving upstream. Literally means actually moving physically to a new place to interact and meeting people where they are.
So Tom, tell us about why that outreach really makes a difference. Why does it matter for mental health?
The whole essence of what we're trying to achieve here is building trust in a community that doesn't have trust in the mental health system. I mean, to say it crassly, whatever it is we're selling, they ain't buying it. And it's important to recognize that even though many of us have this experience that we're helping the people we see, we're seeing a tiny, tiny fraction of the people who could and should be in care. Most of the epidemiological studies that have been done, kind of like door-to-door surveys, find that only about 40% of people who could and should be in care are receiving care. So if we're waiting for them to show up, that's not going to happen. And of course, you know, what makes mental health so different from other parts of medicine is that in this area, the more somebody needs care, the less likely they will be to seek it. As people become more and more ill, if they're depressed, they become utterly hopeless. If they're anxious, they're avoidant. And if they're psychotic, they don't think they're sick. So if we're waiting for them to show up, we're not going to move the needle. The only way we get there is to find them and engage them. And this is where peers can be really helpful, and deliver care really at the speed of trust in a way that allows people to take advantage of the things that we have to offer. And they are good things we have to offer. I'm not talking about just medication, psychological treatments, psychosocial supports, help with housing, help with food insecurity, all of this stuff that is vital for people to recover. And it's important for prevention, but it's not something that we are doing on a regular basis in the healthcare system.
And Ben, I'll let you have the final word on public policy and what changes you really think. You mentioned the block grant before. Are there other things that you think we really need to be thinking about to be able to move upstream and do the things that Dr. Insel said, reaching people that we haven't reached before, making a big difference, reducing disparities, which is another aspect, I think, of that outreach?
Yeah, thanks, Mary, and thanks. It's great to have this conversation with you and Tom. I mean, honestly, I hate to say this, but I really think it's just we have to begin to invest in prevention. As I mentioned earlier, we stymie so much of what we're able to do by not having the appropriate financial mechanisms in place for prevention. Our systems that we currently have, and we in many cases have inherited, they've been grounded in this mindset of we only pay for the problems and what you could do to fix them, and versus how I can pay you to prevent them. It's this constant tension. The dollars that reinforce the same structures, they just simply haven't prioritized prevention. And that's an opportunity for us to really think bigger. Clinics and communities, they're limited in how creative they can be. They're limited in where they go, to Tom's point about we show up where we need to show up. Sometimes we're just frankly limited by how we get paid. And so if we want to go upstream, we have to reconsider the financial models that we've inherited. And I think that's slowly beginning to change. I give a lot of credit to both of you. You know, we are having some different conversations around payment models and policy on the Hill that does begin to reinforce this notion that we can change it. I think there's a couple of things there that we really need to be considerate of, though. I mean, number one, this is kind of an obvious one, but there has to be flexibility in financing. However the money is given, and we can quibble over how the money gets given any day of the week, there must be flexibility tied to it so that the people receiving it can experiment, that they can actually use the dollars for things like startup cost, that they can think about getting away from, you know, oh, I have to be in that setting just to get that payment. And they can literally disperse, or I like to think of it as disintegrate into community so that they can reintegrate into the places that people need them. So flexibility is number one. And so any financial model that's coming forward that does not have flexibility as a backbone is a major limitation. Now, again, we could quibble with policy here. There's a lot of parameters need to go into that, but I think that that is a major principle that should be discussed. Number two is that we've got to measure what matters within our financing and within what we pay for. And a lot of the value-based work that we talk about measurement in outcomes, which is important. We need to be measuring outcomes, but you can't just treat health and measure what matters one disease at a time. And so thinking very creatively about more holistic ways to measure what it matters to the person allows us to also then look at, we'll see how much we saved or gained or whatever, because of the different type of measure. We should be much more creative in our measurements and looking at the outcomes that actually matter to people. I had the great opportunity to be in Pittsburgh last week, and we were talking to folks this week, actually. We were talking to folks about, what really matters to them. And what you'll hear, depending on who's around the table, it could be something as simple as, well, I need a warm place to stay, or I actually need to make sure there's security for my kids. All of these things we don't really measure in the context of healthcare. That's somebody else's responsibility. But if we're going to embrace what we've been discussing today for the last several minutes, then I do think it hinges on our ability to pay for it differently and then to measure it in a way that we currently do not.
And on that note of paying differently and measuring differently, we'll conclude this session. Thank you so much to Tom and to Ben for joining us today. Thank you so much.
Great job, and thank you so much for helping us understand the three kinds of prevention: primary, secondary, and tertiary, the effectiveness of intervening early and doing outreach to connect to people, as well as some of the challenges with financing upstream approaches. We'll talk more about integrating mental health care services and supports, and even mental health education in schools, communities, and primary care in our next two sessions. I'm very excited to welcome our next panelists for integrating mental health into schools, community, and primary care. The first speaker, Paul Jaquith, is part of MHA's affiliate field and serves as president and CEO of MHA of Southeast Florida, very close to my new hometown, with over 35 years of experience in the field of social work. His remarks will be followed by Dr. Matthew Press, who leads integration of Penn Primary Care at Penn Medicine in Philadelphia, and previously helped develop payment and care delivery models at CMMI within CMS. Then we'll hear from Isabel Garcia of Estoya Key, which brings peer support education and suicide prevention resources to traditional and cultural mental health supports, including doulas, librarians, and other non-health service providers in the community. We'll start with Paul. Welcome. Paul, youth leadership has emerged and influenced state policies to improve mental health education, access to school-based services, and supports such as excused absences for mental health. Although some states have led the way, no state has fully enacted a set of laws and policies that would comprehensively improve youth mental health. MHA of Southeast Florida, however, works with schools to identify families that would benefit from skill building to help build healthy parent-child attachment, improve problem solving, and improve communication. Can you discuss how this program works and is funded, and what kind of arrangement was made to partner with the school system?
Yeah, hi Karen, thanks for the question. Mental Health America of Southeast Florida, since we've been a long established partner in the community, we were established in 1957. So we have a long history with the community, including the school system. We have a variety of different programs that we offer to the school system. It has not been easy, however. Forging a relationship with the school system is challenging. Like anything else, they are their own system. And it presented challenges following the shooting at the Parkland, in the community of Parkland at Marjorie Stoneman Douglas 4 years ago now, coming up on 5 years, which changed the entire landscape of how the school system interacts with the behavioral health network. Short of that, we have programs that are funded through different agencies throughout the community that have contacts already within the school system. So we would utilize those contacts heavily to get us in. Having said that, we do have mentoring programs that we utilize existing relationships, long-term relationships with the school system in an informal standpoint. So it's not through contract, it's not even through an MOU. It's really done through our personal contacts with guidance counselors, with principals, other teachers, and so on, to provide those services. Forming a relationship is challenging, especially if it's a new group of people at the school. And I don't know how other states work, but certainly in our community, school staff move from school to school, from year to year, which presents certain challenges, obviously, for us. But what happens is they bring their knowledge base with them to a different school. So I suppose that's the upside to it, is if there's a new opportunity because there's a new staff member, but they know about us, they'll utilize our services. So over the course of the years, we've really been able to forge those relationships. And like I said, the fact that we have funders in the community that are already connected to the school system, like Children's Services Council, ChildNet, and so on, and we have contracts with them, we're able to get into the schools and utilize those services. We'd like to be more involved and more engaged in the schools, but again, it depends on what the needs of the school. And of course, there's competing opportunities, if you will, or competing challenges for schools, because testing is always paramount for them. They want to make sure that the kids are achieving. So to get an opportunity for a child to be excused for a half hour once a week becomes a significant challenge, where it didn't used to be, it is now. Having said that, the state of Florida, back to the original start of your question, our governor mandated mental health first aid as a requirement for all schools throughout the state of Florida, which is the good news. The First Lady is also a big proponent of mental health and mental health stability throughout the school system and for children. So from that standpoint, that's the good news. The bad news, of course, is the legislature, in all its wisdom, and along with the governor, have decided to pass certain bills that are counter to what we normally would expect to see. That would be a mental health, positive, by limiting discussions about things like racial equity, things like transgender, gay, lesbian population, for kids that want to talk about it. It's been a limiting factor, and the schools are scrambling to find ways around to work with it, so that we don't cut off the opportunity for kids to be able to talk to someone in the school that they trust. So there's a lot of challenges left to go, at least in the state of Florida. I know other states have different challenges. Unfortunately, it's not really, I don't believe there's really a national policy that all schools follow. They tend to follow what their states do. So we're always limited and bound by what those requirements are, and try to do our best to work around that. So, to kind of summarize all of that, it's really about the relationship. If we develop a good relationship with the school, then we have that opportunity to work with the school and continue to work with them to the best of our ability, the best of our resources that we can allocate. We utilize a lot of volunteers. There are many people in the community who want to help, who want to be helpful, and want to be part of it. So we utilize those resources as well.
Much for joining us, Dr. Press. We're really excited to have you and wanted to ask a couple of questions about integration in primary care. So considering a person's whole health when providing healthcare is especially important for various reasons, including that it is on average 10 years between when signs and symptoms of a mental health condition first present and develop, and when a person actually connects to services. Integrating behavioral health assessments and interventions into primary care leads to improvements in both physical and mental health outcomes. Can you discuss population level impacts of integrating care? For instance, has the UPenn patient community been able to achieve better health outcomes than before it was integrated? And are all those populations benefiting?
Yeah, I'm happy to answer that, Karen, and thanks for inviting me. I mean, I can say without exaggerating that our program of integrating mental health into primary care has been nothing short of transformational. We launched in 2017, and at that time, like most primary care practices, our practitioners really struggled with meeting the needs of their patients when it comes to mental health. There's limited access to quality mental health care in the community. We know that comorbid mental health conditions with physical health conditions, chronic diseases like diabetes and hypertension, we know that those two things intersect and lead to complications both on the mental health side and on the physical health side. And so when we set out to create our program in 2017, we needed to do something about it. We felt an imperative not only for our patients, but also for our practitioners who, like I said, were really struggling. So the good news is that there's an evidence-based model of integrating mental health into primary care, and it's called the collaborative care model. It's been around for a couple decades and has over 80 randomized controlled trials that show that it improves both mental health outcomes as well as physical health outcomes, as well as lowers the total cost of care. So it's really one of the rare things in healthcare that's kind of a win-win from both the quality and cost perspective. So we took that model, the collaborative care model, basically off the shelf and set out to deploy it in our system. The other key background factor that people should be aware of and that helped us get our program off the ground was in 2017, the Centers for Medicare and Medicaid Services launched payment for integrated mental health for the first time ever. So those billing codes that were created in 2017 allowed us to envision a financial model of sustainability. In the past, when collaborative care was deployed in health systems, it was often a short-term funding, and the program went away after the short-term funding went away. So we felt that through the billing codes, we would be able to establish a program for the long term. So clinically, we took that model off the shelf, and basically collaborative care, it's a team-based approach. So you have the primary care practitioner as well as a behavioral health care manager. They're sort of the core of the team and the patient-facing part of the team. But then in the background, you have a consulting psychiatrist who's there to meet weekly with the behavioral health care manager to manage an active panel of patients who are enrolled in collaborative care. It's really a disease management approach, as well as provide support to the primary care physician. And what that does is it takes that really scarce resource of psychiatric expertise and spreads it over a much broader population of patients, because the psychiatrist isn't directly seeing patients. The psychiatrist is there supporting the PCP and the behavioral health care manager to carry an active patient load of about 80 patients at a time. And those patients cycle in and out every 3 or 4 months. So you really are able to deploy that expertise over a much bigger group of patients. The other key part of the collaborative care model is the registry, and this idea of proactively enrolling and monitoring patients and using standardized assessments to see where their symptoms are. Are they getting better? Are they getting worse? And that's the kind of thing that the psychiatrist reviews with the care manager on a weekly basis. So this is really a disease management, population health, team-based approach to integrating mental health in primary care, and again, has strong evidence that it works. So when we launched, we developed the program in 2017 and launched in 2018. We thought we would, or we hoped to see 500 patients in that first year, and we got 5,000 referrals. And that just confirmed for us how important it was that we do something about mental health, confirmed for us that our practitioners were struggling to manage the prevalence of mental health conditions, and it confirmed for us that our patients needed this service. So here we are now, about 5 years later. Our program is in over 20 of our practices across the Penn network. We still deploy the program very much adherent to the collaborative care model. And for those who are looking for more detail or guidance on how to deploy the collaborative care model, I'd refer you to the University of Washington Ames Center, where there are a lot of great resources on how to do that. We continue to support our program through the billing codes for collaborative care. And so I would encourage everyone to work with your local payers to ensure that those codes are covered and that you can support your program.
So let me just ask one other question, Dr. Press. Even with the success that you're talking about of using an interdisciplinary team to carry out collaborative care, uptake has been less than speedy, and there have even been transformational grants for practices to use. Can you talk about maybe why it's been slower to scale and what financial incentives are that support it?
It's a great point. I mean, here we have this intervention that we know works and that can be delivered efficiently and effectively. And you're right, Karen, it's still in limited use. And I think there are a couple obstacles that are preventing the more rapid deployment of collaborative care. And these are obstacles that are that we can overcome. So the first one actually is related to the electronic medical record. So a big limitation for us when we first launched the program was getting our electronic medical record set up to capture the documentation and support for billing of collaborative care. So that's really essential that the electronic medical records deliver a turnkey solution to deploy collaborative care. The other piece is the training of the staff. So we use licensed social workers or counselors in our program. They didn't come out of school with training specific to collaborative care, the brief interventions that are used in collaborative care. So we developed a training curriculum for them, as well as actually our psychiatrists and PCPs. While they were all in favor of doing this program, they needed some of the skills to deploy as part of this program. And then the last piece is financial, Karen. There are startup costs. We're fortunate to have been in a healthcare system that was willing to commit startup investment to build our program and get it off the ground. And so absolutely payers and others who can support practices, particularly small practices and independent practices that are not part of a system, to get them the support and off the ground. That early financial support can get you going, and then the billing codes can support you thereafter.
That's really, really great, quick summary of how you all have effectively used training and influx of initial financial reserves to support collaborative care within your network. And you point to an issue that is being discussed even today with sponsoring office Congresswoman Matsui, who has the Behavioral Health IT Act, or the HITECH Act, which would give some support to practices that want to use electronic health records, because many behavioral health providers were left out of that initial kind of HIPAA funding that went to doing so, to adopting electronic health records and practices. So thank you so much for sharing about the program that you all have, and as well talking about some of the issues that can be addressed in future legislation or policy making that CMS does to support practice transformation, so that that any primary care physician or practice is thinking about how they can integrate and has the support they need to do so. I will go ahead and turn it over to Isabel now, who will provide some input on her program in training community leaders like pastors, librarians, beauticians, hairstylists in mental health, and how to identify signs and symptoms to maybe refer someone to services. Thank you.
Thank you.
Hi, Isabel. Thank you so much for joining our panel. We're really excited to have you here today.
Yeah, thank you so much.
Our first question for you really drives to the heart of your organization, Estoy Aquí. We know that a culturally and linguistically competent mental health system incorporates skills, attitudes, and policies to ensure is effectively addressing the needs of people and families with diverse backgrounds, values, beliefs, and sexual orientations, gender identities, in addition to disability, race, religion, language, and socioeconomic status. It also works towards incorporating a culturally humble approach that focuses on mutual respect and ongoing introspection and learning. Can you tell us about how Estoy Aquí really embodies these beliefs and helps to grow cultural humility in health systems and throughout the community?
Yes. I should start by saying that Estoy Aquí, which means I am here, is a training and education organization. And so when it comes to cultural humility, we are all about it because we really focus on the relationship between suicide and mental health and social justice. So we look at that link between the three. And we focus on providing this training and education to organizations that primarily serve the Latinx and Black population. And so this can be offered in terms of professional development, things like workshops or seminars or presentations, to social services, healthcare providers, counseling professionals, high school, college students, and of course the overall community. And so when it comes to cultural humility, our main goal is to really raise that awareness that about the underlying social and cultural factors that create conditions for suicide and mental health challenges to exist in these populations. And we do this in multiple ways, right? We promote cultural humility in multiple ways. So there is, yes, my training curriculum. There's also the circle practice that I offer. I call them community care circles. And there's also my outreach program, which is called La Cultura Sana, which means the culture cures. But I will say overall, the main way that we promote cultural humility is through the power of language. I am a believer that language really shapes our experiences. It's really an empowering tool that defines our reality and that can help us fight the injustices we face every single day. And so, for instance, when you look at my training curriculum, I have a suicide prevention training series, and there are 3 parts to it. There is the suicide from a racial justice lens training, there is the mental health beyond the individual training, and there is the interrupting suicide with community care training. And each one of those focus on these culturally relevant care, social, cultural, and racial relevant care. By talking about compassion, how do we talk about mental health and suicide in a compassionate way, in a way that is non-coercive, in a way that addresses these cultural factors that affect the lives of, let's say, the Latinx population? So for instance, I talk a lot about assimilation and acculturation in immigrants. How does that look like? How do we talk about it in community and also as a provider? How do you talk about that? How does that come up in your practice? I talk a lot about microaggressions. What are racial microaggressions? How do you pinpoint them? How do you address them? I talk a lot about machismo and marianismo, which is very predominant attitude in Latin American countries, right? And I could keep going and going and going about all of these social and cultural conditions that really shape our reality, our experiences, specifically with mental health and suicide. And so I truly believe that when talking about these factors, cultural humility comes in the sense that we talk about curiosity a lot, especially when talking about community care. How do we interrupt suicides, or how do we talk about mental health with others? I talk a lot about curiosity, about validation, about consent when supporting others. And I talk a lot about looking beyond this idea of individual responsibility and looking more at the systems and practices that impact our well-being. So I will say in a summary, there are just different ways that Estoy Aquí practices cultural humility, the values, the actual content of the training, and just our overall goal.
Excellent. Thank you so much. I heard so many great points there, but in essence, Estoy Aquí is kind of a harbor of the language and knowledge that mental health providers and other community leaders can use, because you're training not only clinicians, but also librarians and beauticians and barbershop owners and other people that interact with our community on a daily basis. One last question. During a behavioral health workforce shortage, it's already difficult to weed through inadequate networks of providers, and even more difficult if you are looking for someone that shares your culture or speaks your language. A lot of people are also unsure of how and when to reach out to ask for help if they're struggling. Do you have a suggestion for how counties, states, and health systems can work with organizations like yours to educate, refer, and support the mental health needs of a community?
Yes, I do. And I mentioned already my outreach program, which is called La Cultura Sana, The Culture Cures. And that is the program where I reach out to the barbers, to the hairstylists, to the librarians, to the herbalists, to the funeral staff. I mean, we're talking about a long list of mental health stakeholders that are not necessarily recognized as mental health stakeholders by the system, by the public health system or the psychiatric system, because they don't have, let's say, a license or a graduate degree. But regardless, they're still doing the work. They're still providing social emotional support to the community. And so through La Cultura Sana, I have been providing peer support training to these stakeholders.
Thank you so much, Isabel.
Thank you so much for having me.
Hi, all. Integrating mental health education services and supports in schools has been a priority for MHA, as well as many states and the current federal administration. Evidence points to continued decline of youth mental health, and why not meet students where they are? I'm pleased now to welcome Kelly Davis, Mental Health America's Associate Vice President of Peer and Youth Advocacy, who leads MHA's 2 youth councils, the 2 young adult leadership programs, and will now present our annual Advocacy Award to highly deserving youth.
Hi, everyone. I'm so excited to be here today to talk about the role of youth and lived experience in young people in addressing the current youth mental health crisis. I'll talk a little bit about my lived experience and how that ties into the work that we're doing at MHA today, some of which you'll hear from other folks who are working on. So my lived experience as a young person, I always felt like there was something different about me and the way that I experienced the world. Sometimes it felt like my feelings were physically too big for my body. And by the time I was 10, I had my first suicide attempt and spent much of my teenage years and young adulthood in all sorts of different mental health services, inpatient, outpatient. And it felt like not only could I not figure it out in the way that all the other young people to me seemed to be able to, but whatever it was that I was dealing with was so bad that I couldn't even talk about how I was spending all of my time trying to get better. And by the time I was 19, I was diagnosed with bipolar disorder and essentially given the message that people like you don't do well, go home, don't stress yourself out too much. And it was at that time that I got connected to the peer support movement. And the peer movement really taught me that there was hope, that there were people like me who lived full and fulfilling lives, who were amazing and contributed to the world around them. And that there were things that I could do for myself and in community with other people to make the world better. And after that, I got involved as a mental health advocate, where I would share my story and people would say, your story is powerful and moving, and then they would do the same thing. And the point I feel of my story is really a lot of what we do for people, as someone who got a lot of the traditional way of doing things, is upside down, it's backwards. It's the community members, it's having this language to talk about your struggle. It's having people who you can talk to about it. It's making sure that wherever you actually want to be spending your time, whether it's in sports, whether it's in art, whether it's texting, online, and gaming, wherever you are, that mental health support and mental health resources are available to you. And young people across the country, through Mental Health America's leadership program and all sorts of leadership programs, are really taking the lead and saying there's this huge problem, and young people are critical parts of the solution, whether they are creating general mental health awareness campaigns, whether they're doing peer-to-peer models in schools, which we'll hear about in a little bit, or they're going into traditional mental health settings in foster care, juvenile justice, inpatient psychiatric units. There's so many different ways that young people can make a difference and lead. So I'll just say for today, one of the clear messages is it's not just adults being empowered to support other adults, but young people can do it, but are really, really leading the way in advocacy campaigns and research and all of these spaces to say, okay, there's not enough resources for me, and guess what? This isn't exactly how I want them anyway. So grateful to be here with you all in this movement of lived experience and young people making a difference. And I'm really excited that I'll get to quickly introduce two young people who are doing just that, who just secured a $10 million for peer-to-peer programs in high schools in California. And now I am incredibly excited to announce this year's Mental Health America Youth Advocacy Award to two young leaders from California. We started this award in 2021 as a way to acknowledge a young person or young people who are making a difference and taking action in their communities to address mental health. I'm excited to present this year's 2022 Youth Advocacy Award to Shreya Chilla and Nia Doe. They are two recently graduated, Stanford and UCLA, so if you're there, hit them up, high school students who have been featured on local, state, and national scales because of their tireless efforts to bring peer-to-peer models to high schools, something that we have really talked about and are spending time thinking about today, and is so critical in a landscape where there's such high need among young people and so limited resources. So have just been really inspired, all of us at MHA, about their work and how it's influencing the lives of other young people across the country. So with that, I will say congratulations, Shreya and Nia, and I will turn it over to both of you for you to share your thoughts and your process and accept the award.
Yeah, thank you, Kelly, for your kind words. We're both Tree and I are incredibly excited to receive this award this year, right? I think the journey has been incredibly rewarding for us. It was a lot of work and a lot of hardship navigating through the difficult systems that's not trying to change itself, right? So until there's a crisis going on like COVID-19 on young people's mental health, and then there's momentum to change, right? And we're so glad and grateful to be a part of that momentum to push for change. I think one of the things that we're passionate about is peer-to-peer program, because it promises to utilize the rich resource of young people directly on campuses to be able to address the different issues of mental illnesses and mental health directly on school campuses. So not just relying on professionals, but also building a culture of care and of safety and community directly on school campuses, utilizing the youth on that campus. I think the reason why peer-to-peer work is that young people are more likely to turn to others when they need help, based on a lot of research and evidence-based practices, right? And we want to be able to expand this in all across high schools in all California, and not just in California, but all across the nation. like recently, Shri and I were successfully, be able to do like a advocate for a successful demonstration project within the California governor's budget of $10 million. So that's currently happening, and it's going to the governor's desk for signature and to be signed and get it into practice. So that's incredibly exciting for us. We're just incredibly grateful for all the mentorship from Alex Bisco from the California Children's Trust, California Coalition for Youth True on Wilkes, and other amazing folks who has helped us and mentor us through this process. So passing it on to Shreya.
Yeah, thank you, Kelly. Thank you, MHA, for believing in the work that we do and supporting us in this work and in this very needed advocacy. I also want to thank the CMACI Board, California Mental Health Advocates for Children and Youth, for being such great mentors, as well as Chris, Stoner Mertz, and Ken Barrick for also just developing us as people as well as advocates. I want to say again, thank you for this award. It means so much to me because it really represents the Youth Advocacy Award, youth being at the center of advocacy and being at the center of policies and programs that ultimately serve them. I believe youth need to be at the center of the care because they know what's best for them. And we need more youth voice represented not only as checkboxes that we need to get done when we're implementing programs, but as actual partners when we are developing the program itself. What we often talk about with peer-to-peer, which is what we won this award for, is that it is a prevention model. We are providing this care directly on school campuses before mental illness, which usually doesn't develop at full severity at the high school age, before mental illness develops at that full severity in later years. We're providing these youth with healthy coping mechanisms in order for them to deal with those issues later in life before they snowball, and we're not chasing after the fire, trying to treat it with medication and drugs. We're treating it as people. And so my only hope is that I can see other people walk the stage, receive this award, and really make their voice known, and that future generations have mental health care access in an equitable fashion on their school campus. Thank you.
Just kudos to these remarkable young people taking their advocacy beyond even their school and community to impact the state. Clearly, Nia and Shreya are fantastically intelligent, and I look forward to seeing their vision implemented in California so that other states may adopt similar peer support models in their school districts. To conclude today's program, I thought we could quickly summarize what we learned from our incredible speakers, prevention of mental health conditions and public health and what it should consider. We heard about technology, the importance of data collection, some of the workforce needs that need to be addressed through existing programs that can be scaled, and long-term investments rather than gearing up for crisis after crisis. Early intervention and public health should also consider some of these ideas, and of course, integrating mental health education services and supports should be a focus. We'd also like to note a couple of areas of improvement that could be bedrock for future changes in public health. Sydney?
Thank you, Karen. One opportunity for improvement that I see is with interagency communication, coordination, and collaboration in the field of mental health. We've heard today about the different roles certain federal agencies play in public and mental health, and we have seen a few areas of intersection. However, in order to continue to do this work more effectively and more efficiently, there will likely be a need for strengthened communication across agencies and many more opportunities for interagency collaboration. And to make that happen, federal funding needs to be made flexible enough for multiple agencies to use it to work together. Another area for growth that I think was brought to light today is incorporating and elevating the youth voice in these policy conversations. We've heard from young people both today and in our work on a daily basis that they are interested in this work, especially in prevention and early intervention spaces. And they have proven time and time again that their lived experiences generate powerful ideas on how to address student and youth mental health in a way that meets young people where they are. For that reason, I think it's incredibly important to include and amplify the voices of young people with lived experience at the highest levels of decision making moving forward. With that being said, I would just like to extend a special thank you to Kaiser Permanente and our absolutely incredible speakers for making this amazing event possible.
Sydney, very insightful recommendations, and thank you so much for closing us out. We appreciate everyone who tuned in today. The recording will be available to you on YouTube at the same link, as well as links from the chat, which you can revisit at any time once this final video is uploaded and finished. Have a good afternoon and good mental health to all of you.